Then today we will have two honored international speakers. To the main focus of this course, the discussion about what can laryngeal EMG give us on additional information. Can we conduct the prognosis from EMG of recurrent laryngeal nerve paralysis? And a lot of members of this course in the years before told us that they would like to have more basic information about EMG and how the signal is produced in the muscle structure. Therefore, we are really grateful that Wilhelm Schulte-Mattler, the most famous German neurologist on the field of EMG, will give us an introduction on EMG. And in the later part of this course, Clark Rosen, one of the famous US laryngologists, will share his ideas with us about quantitative EMG and more advanced EMG. So this is the program for today. Here we are located in the center of Germany. The cities of Jena and Gera are nearby, half an hour by highway. Why we do these courses? We came from laryngotracheal stenosis, laser surgery, thyroplastic surgery, and then we found that the function of the larynx can only be restored if you learn more about neurolaryngology. We are the founders of a scientific project concerning laryngeal pacing. We established in our departments laryngeal EMG, and we perform a lot of laryngologic procedures and surgeries, for instance, planar innervation, augmentation, thyroplasties, and we organize since 2011 neurolaryngology courses for experts and for beginners. So these are some of our recent publications. You see, we are working on different topics about laryngeal EMG, about synkinesis, and on laryngological aspects. This is the history of our workshops. You see, we had a lot of famous persons on the field of laryngology as guests in this course. And this year, we are proud to have Walter Schulte-Mattler and Mark Rosen as guests. In 2019, we had the development of our course that delegates from 11 nations joined our course 2020. And this year, we have a reduced course because of the travel restrictions and the corona pandemic. So we are hopefully looking forward to the next year to have this course again as an international course with real participants. So this is the schedule for this afternoon. After my words, we will start with the presentation and we will end up around 6 p.m. and you have between 4 and 4:15 a bio break. And then we try to get the line to San Francisco. So this is the program for today, and the other information for tomorrow I will give later on. So now I would like to introduce our first speaker, Professor Wilhelm Schulte-Mattler from Regensburg. He is one of the most experienced neurophysiologists in the field of neurology. He has written a standard textbook on EMG in the German-speaking area. This is the most noticed book on this field. And he's really didactic, and I think he can give us really an introduction what goes on in the muscle fibers if we stick a needle in, and what we see on the screen or what we hear with our ears during EMG. So, Professor Schulte-Mattler, welcome to you, and I would like to give you the mic.
Hi, thanks for the introduction, and thanks for the opportunity to join this meeting. It definitely should be very interesting, not also for ENT, but also for neurologists. Should be interesting. So, as I have the mic, we're early. Is it okay if we start right now for the sake of time, or shall we wait until 1 p.m.?
I think we can start slowly.
Slowly. Well, then hello to the audience. I hope this works. Can you see the first slide now?
Yes.
As intended, I'll try to give you a brief introduction into electromyography and what it has to do with pathophysiology of paralyzed vocal folds, but not only of vocal folds. Actually, muscle physiology or neurophysiology of neuromuscular disorders, in this field, it doesn't really make sense to differentiate between cranial muscles and muscles of the body. The main difference between those cranial muscles and extremity muscles, limb muscles, is their size. And of course, the ENT fraction, the ENT department, is very well able to handle with these, to deal with these small muscles manually. And indeed, this is the main difference. So I will focus on pathophysiology of muscle and nerve and what EMG can do for us. And keep in mind, this is the key to electromyography. Always keep in mind, please, that all of our muscles are organized in motor units. The motor unit, this is the alpha motor neuron or the nuclear neuron in the brainstem. So there are those neurons. Here's just one as an example. And those neurons are wired or connected to the muscle via one fiber, one axon. And this axon, like the roots of a tree, for instance, splits into subdivisions and is connected to a number of muscle fibers. This is important to keep in mind, that one axon drives many muscle fibers. In limb muscles, it's from 100 to 500, with some exceptions. And in the cranial muscles, it's less muscle fibers per motor unit. So it may be as low as 10 in extraocular muscles, 10 to 20, or some 20 to 100 in most of the other cranial muscles. Again, this is just a matter of quantity. The difference between those cranial muscles and the limb muscles is not of crucial importance. What is meaningful is, or what is important, that this one neuron is wired to some muscle fibers, and that there are many neurons that are not in display in this slide here. This is just one example. And we record in the left part of the image, you see our needle electrode. We insert a needle into the muscle, and the needle will record the signal of some of those muscle fibers that are close to the tip of the needle. And what we record is displayed here, is the so-called action potential. And one action potential follows one discharge or one action potential of a motor unit. It travels around here and generates a muscle action potential that can be taken up by the recording electrode. That's what we do when we record electromyograms in cranial muscles as well as in limb muscles. And the goal of electromyography is to differentiate the various types or grades of nerve lesions or muscular disorders. We won't deal with myopathies here, so we just talk about the various grades of nerve lesions. And one method to differentiate or to name those lesions is displayed here. The normal nerve is shown in the upper line, transmits the electric impulses. We call it saltatorily. That means that the electrical voltage travels, it jumps from one node of Ranvier to the next one with a certain speed. And the speed at which it's done is determined by the distance between those Ranvier nodes. And if the myelin sheath is doing well, we have some conduction velocity as expressed in meters per second that ranges from some 50 to 60 meters per second. The conduction velocity can easily be determined in peripheral nerves, such as in the median nerve of the arm, for instance, but it cannot be determined in cranial nerves, as the measurement of the conduction velocity, which is done by the method called electroneurography, requires that we stimulate a nerve electrically at two different sites. And we can't do this in the cranial nerves, with the exception of the facial nerve, for instance, but the facial nerve can only be stimulated at one site, not at two different sites. So we're unable to determine this conduction velocity. It is meaningful to determine that conduction velocity to detect this kind of nerve lesion called demyelination. Demyelination happens upon repair of the myelin sheath. So if myelin sheaths get compressed and the myelin sheath is compromised here, the recovery process usually leaves the myelin sheath in a way compromised. And where the myelin sheath had been compromised, the conduction velocity is lower because the distance between those Ranvier rings is reduced. So demyelinative disorders can be detected by conduction velocity measurements. So it is not easy to detect the demyelination in cranial nerves. In most of these nerves, it's impossible. It is not that meaningful, as demyelination usually occurs with inflammatory disorders or with compressive disorders locally. Well, another kind of nerve lesion is called neuropraxia. Neuropraxia is an acute, normally caused by an acute lesion of the myelin sheath, and it blocks the conduction of the nerve. Here, in this instance, conduction velocity is reduced, conduction is slow, but conduction does not take place in this kind of nerve lesion. So what is the clinical correlate of this? This is, if it's a motor nerve, the clinical correlate is weakness or paralysis. The electrical properties of this nerve are intact, with the exception of this segment here. Cause of neuropraxia usually is compression or ischemia. A more severe kind of nerve lesion is axonotmesis. That means the axon, the nerve fiber itself, is structurally damaged. The result is similar to what happens in neuropraxia, namely, the conduction does not take place. So the clinical correlate of this condition is the same as with neuropraxia. In both instances, the conduction does not take place. The result is weakness or paralysis. Now, please keep in mind that one nerve is not only one fiber. This image here shows what happens to one fiber. In a nerve, both conditions, neuropraxia and axonotmesis, may well coexist. So some of the fibers may be damaged, axonotmesis. Some of the fibers may be neuropraxic. So if all fibers are hit by the same disorder, but only some are neuropraxic and some are axonotmetic, the recovery is determined by the number of neuropraxic fibers, as the recovery in neuropraxia is usually quick and complete. So there will be no scar, nothing, no remainder with this fiber. The recovery from axonotmesis is different. It takes place very slowly. The axon must grow from this site towards its distal part. And this takes place usually at a speed of 1 millimeter per day. So the recovery process is quite different between these two conditions. And therefore, it's of crucial importance, to differentiate these conditions, to determine what has to be done to provide recovery to the patient, not only to the nerve, but to the patient. So remember, neuropraxia and axonotmesis, we must know what percentage of axon, or we must guess what percentage of axon is affected by one or the other type of disease if we have a patient with some kind of weakness. Sorry, a busy slide. We'll repeat that a couple of times. It is not, you need not to learn this by heart. It just the idea is to show you that the different kinds of nerve lesions here, neuropraxia, axonotmesis, and neurotmesis, I will show you in a second what this is, have some consequences as determined by electromyography or neurography or ultrasound. And there is a certain sequence, time, in which the phenomena occur. This is here are some times given this display that are important, as they are kind of milestones that are passed by a disorder or by recovery. We need to know what is partial axonotmesis or total axonotmesis or neurotmesis. What does it mean? I told you that the axonotmesis or neuropraxia is taken or is expressed per axon. If some of the axons are axonotmetic and some are not, we call this a partial axonotmesis. If all of the axons are damaged, we call it a total axonotmesis, logically. And we differentiate this from neurotmesis. This is a condition in which the whole nerve is damaged. Total axonotmesis says that the structure, the outer structure of the nerve macroscopically is intact. Neurotmesis means that you see macroscopically that the nerve is damaged. For instance, it may be dissected iatrogenically or by trauma. These conditions, it's of crucial importance also to differentiate these conditions, as a nerve that is neurotmetic will never regain any function without surgery. In these conditions here, it is more difficult to determine what is to be done, as the prognosis is different depending on the time and the severity of the lesion. And I'll show you some of the EMG findings that help determine what kind of lesion we find. And keep in mind that those changes in EMG, the pathologic findings, have a timely sequence. They do not all of these changes occur immediately upon a lesion, but it needs some time for those phenomena to develop. We'll go over this. This is a situation we have with our needle EMG. You see here a dissection of a muscle, and you see the needle, and this is redrawn from a microscopic picture. So the needle has some size, and what you see here is muscle fibers in a cross section. Those green fibers represent the muscle fibers belonging to one motor unit. You see they are scattered around in the muscle and not packed, not clustered. And you see that there's some space between those fibers on one hand. And you also see here two circles across the needle. The outer circle somehow represents, semi-quantitatively, the uptake area of the needle electrode. So those fibers within the outer circle contribute, or mainly contribute, to what is recorded electrically by the needle electrode and what is displayed on the screen of the EMG equipment. EMG is seeing, like an oscilloscope, what happens electrically in the muscle. The inner circle, semi-quantitatively, represents the uptake area for what we hear when doing EMG. Only few muscle fibers close to the needle tip contribute to what we can hear. So when we're doing EMG, we have a loudspeaker, and we have a screen, and they synchronously display or make audible what is in the muscle. And those fibers here contribute to what we hear, and many of the fibers of the motor unit, but not all of them, contribute to what we can see. And now, first phenomenon. Imagine this situation. The needle is in the muscle, and only this green fiber is discharging electrically. How can this be? Remember, those muscle fibers are connected to their anterior horn cell or motor neuron. And if the motor neuron discharges, the muscle fibers will discharge. And in a healthy muscle, this is the only way for a muscle fiber to discharge. The only condition that makes a muscle fiber discharge is when it gets a command by its anterior horn cell, or by its motor neuron. The motor neuron says, motor fiber, do discharge, and it will. But if a motor neuron says discharge, or it does discharge, all of the muscle fibers of that motor unit get the same command and they discharge. So this particular situation of one muscle fiber discharging will never occur in a healthy muscle. And this is what makes these discharges of single muscle fibers a pathologic finding. And they are labeled pathologic spontaneous activity. Why is the name pathologic? Because it is the case. It truly is the case. If we find this, if we trap this situation in the muscle, we may be sure that there is some pathology with the muscle. It is not fully specific for any process, as neurogenic processes may generate or may cause pathologic spontaneous activity, and myopathies may do as well. In our context, we deal only with neuropathies, and pathologic spontaneous activity now shows that there is something wrong with the axon. Axonotmesis will cause pathologic spontaneous activity. Neuropraxia does not. So it's a way to differentiate or to learn whether axonotmesis has taken place or not. However, it is not as easy to determine that only one muscle fiber generates a signal. This is kind of typical signal we can record when doing EMG. This is a physiological motor unit potential, just to show you what we can measure. We can measure amplitude here from A to A. We can measure duration. We can count the phases, the components above and below the baseline, or we can count the turns, the turning points in the signal. All these measures can be done, measurements can be done, but none of these values differentiates whether this is one muscle fiber that is discharging or whether this is a motor unit. For instance, intuitively, you may guess that the measurement of the amplitude, if it's low, will show this is a single muscle fiber. And if the amplitude is high, we will guess that is a bundle of muscle fibers, that's a motor unit that is discharging. Unfortunately, the range of the range of amplitudes of single fibers and the range of amplitudes of motor units overlap to such an extent that is virtually impossible to determine by amplitude measurement whether we have a muscle fiber discharging or a motor unit. And it's even worse. Here you see two signals. That is our original EMG recordings. This is 1 second in duration. And this is 1 second in duration. Both signals are recorded without any voluntary effort of the individual studied. So the activity is spontaneous, as there is no voluntary effort. The question now is, which of these recordings represents pathologic spontaneous activity and which one is normal? Actually, one of these recordings was taken from my own biceps muscle, left biceps muscle, some 30 years ago. So since then, this muscle was pretty well working. So we may guess that this muscle was well at that time. The other recording is taken from a totally denervated hand from a person who had an ulnar dissection. So one muscle was totally denervated and the other muscle is, I feel, totally well. Which is the pathologic one? Well, we can try to interact. Is there any possibility to interact with the participants? So I'd like to learn what you will guess. Which registration is the pathologic one and which one is not?
We could ask the participants to go thumbs up for the upper line by reactions. So like this. This would be a vote for the upper line. Or you can unmute you. You're free to share your picture and your mic.
Keep in mind, there's exactly one solution. One is the pathologic one. There is a chat.
Chat is also fine. Yeah.
Up. One participant guessed up is the pathologic one.
So please all raise your hand if you think line 1 is the pathologic one. Kann ich den Daumen hoch machen?
Of reaction.
Ach so, Reaktion.
The upper one or the lower one. Keep in mind, this is original registration, and we need to make it to decide which one is the pathologic. In reality, we must decide whether we feel it's pathologic or not. Upper line is pathologic, upper pathologic. Many votes for the upper line. Anyone who will comment on why he or she considers the upper line pathologic. Well, we give a solution in a second. First, we dissect the image. Here, you can see enlarged visions of parts of these waveforms we displayed a second before. This one, you see the scale is changed. Now it's enlarged vision of one of those two waveforms. And potentials that look like this one here. They are small, low, and start with an initially deflection downward. Those potentials usually called fibrillation potentials. It's a trap. It's a problem with this label, as if we call this a fibrillation potential, we wish to imply that we consider it pathologic. The use of the word fibrillation always implies we give it a pathologic meaning. And this looks like a fibrillation potential, very exactly. It resembles a fibrillation potentials, but it is not. It's from my biceps. Similarly, potentials that look this way, that start with the downward deflections, they are sharp and have some after discharge here. Those potentials are called positive sharp waves, and they're considered pathologic too. So if you use the word pathologic sharp waves or positive sharp waves, positive is downward deflection in electromyography. If you use this term, you consider this pathologic. Positive sharp waves are always pathologic. Unfortunately, again, this one just resembles a positive sharp wave. It's from my biceps. It exactly looks like a positive sharp wave, but it is not. This one here at the right-hand side, it starts with an initially upward negative deflection. Potentials of that kind are called benign fibrillations or end plate potentials or end plate spikes. They are considered normal, and you usually find them as the name says, in the end plate region of the muscle. And this normal potential is recorded from the totally denervated muscle. So the message here is, it is definitely impossible just from one potential, from any of its measures or shape or so, get a solution or get a clue to whether it's pathologic or not. Here's a solution. This is another registration, another recording, 1 second of abundant pathologic spontaneous activity. And to illustrate what I mean is I have marked discharges of the same fiber as indicated by the same shape and size or so. And we measured the distance, the time interval between two subsequent discharges. And you see all these differences are quite similar, are very exactly the same. And this is the hallmark of pathologic spontaneous activity, that the interdischarge intervals of the same fibers are quite constant or change in a quite regular manner. You can display this graphically. Here's the interval, the milliseconds, and this is the first interval, the second, the third interval. And if you stretch the y-axis, you find a straight line. This is without the scale, and you can do this, the same procedure for all of the events here in this spontaneous activity, and you'll always find straight lines. They may climb a little bit, or rise or fall, but they are always straight. In contrast, this is voluntary activity, physiologic activity. You see up and down here with this kind of display. You see the discharge behavior is slightly irregular. So we have a first conclusion how to surely determine whether there is pathology in the EMG. That is, if you find a very regularly discharging event or potential, you may be sure it's pathologic. Regularity implies pathology. Irregularity implies usually that this is normal. The conclusion, when it's regular, then it's pathologic, holds very, very robustly. To determine whether it's regularly or not, you may measure the intervals. And you will hear it is displayed that you never find the same interval another time. So the intervals are changing a little bit, but they're always a little bit different, which is not the case in pathologic spontaneous activity. So if it's regular, it's pathologic. And the solution, you were right, it's the upper trace. For instance, this one here, this is a positive sharp wave, and it occurs here and here and here and here. And if you measure the interval, the interval distance, you'll find that these intervals are exactly the same. You can display this in a wall with a beamer, overhead beamer, and take a measure, do the measurements, and you for millimeter per millimeter, it's absolutely exact. All of the events here in this waveform occur regularly, so it's pathologic. And this registration, well, it was a little bit painful for me at that time. It's from my end plate region. And the potentials resemble fibrillations. This is a common beginner's mistake, to record from the end plate region of a muscle and mistake this here for pathologic spontaneous activity. It's spontaneous, but it's not pathologic. It's strictly irregular, and thus it's not pathologic. Okay, when it's pathologic, when it's regularly, it's pathologic. And funny, you can determine the regularity by interval measurements, but you have an instrument built in your head. And this is, I think it's maybe your profession, namely our ear or our auditory system is very well capable of determining the regularity of these discharges. With only a little training, you can determine this just by listening to the regularity, to the firing pattern, and you can decide whether it's pathologic or not. A little training is required, but it is not too difficult. And as I said, your ears or your auditory system is very well equipped to be trained this way. When does this pathologic spontaneous activity occur, and in which condition? Pathologic spontaneous activity needs some time after a lesion to develop. It's 10 to 14 days until the first pathologic spontaneous activity occurs. You see here, after 2 weeks, you find it. PSA is pathologic spontaneous activity. The other things we go over later. And you see it occurs from the third week, from after 2 weeks. And this is very important. After a severe lesion, it may persist even after recovery. There may remain some muscle fibers sending pathologic spontaneous activity as long as more than 50 years after lesion. So we probably can say for the whole life. So it's another common mistake to take pathologic spontaneous activity as evidence for a new lesion. It may persist after years after the lesion. The intensity lowers, so the amount of pathological spontaneous activity will be reduced over time, but it may well persist. So pathologic spontaneous activity is pathologic. It occurs after 2 weeks after an axonal lesion. Neuropraxia never causes pathologic spontaneous activity. Of course, a mixture, partial axonal-mesos, maybe neuropraxia plus axonal-mesos will cause it. And it takes 2 weeks. And this is the reason why in many textbooks you will read, do electromyography not before 2 weeks after a lesion. We will learn that this is wrong. But it holds true for pathologic spontaneous activity. This activity needs 2 weeks to develop. We have another issue. Again, the same picture, the needle is in the muscle. We see the fibers of one motor unit discharging or not. And now we'll discuss the complexity of voluntary activity. Here I have colored a second motor unit. And you see that all these fibers are scattered, and the relationship between the motor units is stochastically with no regularity. However, our needle will take the activity not only of the green, but also of the red fibers, and we hear both the green and the red fibers. And we'll need to go over this slide for some time. What is happening here? The left-hand side is a healthy muscle. Again, I know this muscle very well. On the right-hand side, we see a muscle of a person who has a neural lesion. We'll see which kind of lesion. Top down, the first waveform here is, again, it's 1 second of duration. You see those spikes here, 1, 2, 3, I think it's 9 or 10 or so during this second. These are the action potentials of one motor unit. So this is a minimum effort. So the person who studied here, actually myself, was activating just one motor unit within the uptake area of the needle. This is the lowest degree of voluntary effort one can produce. If it's less than one motor unit, it's 0, so it's relaxation. And if one motor unit is innervated or recruited, usually we'll see minimum muscle contraction or not at all. This is very, very weak voluntary effort. And this motor unit discharges at about 10 per second. And from top down now, more and more force is generated by the muscle. So the second registration, the second recording here is the same motor unit. And you see here, and later on here, a second motor unit is taking part in the contraction. We say it's being recruited. And here, third line, fourth line, more and more motor units contribute to that contraction. And this is how muscle force is controlled in the human body. This is the number of motor units taking part in a contraction. The more motor units are contracting, the higher the force output of the muscle is. And if you see here, you find the discharge rate of this is always the same motor unit here. The discharge rate is not very much increased. It's about 12. Here it was 9, 10, 12 per second. So with lower muscle effort or medium muscle effort, the force output of the muscle is controlled only by the number of motor units taking part in the contraction, and not so by the discharge frequency of the motor unit. This is very important. The fifth line here down below shows what we call an interference pattern. This is about maximum voluntary effort. So all motor units are taking part in the contraction. All motor units, what we say, are recruited. And we can see that we cannot see anything. We cannot differentiate the discharges of single motor units. It's just, as the name says, it's an interference of all these discharges. And what we cannot do here is determine any discharge rate of an individual motor unit. It's just many ups and downs, many turns. We call it a full interference pattern, as there's no interval where we can identify the baseline, and it was the case here. So full interference pattern and a crazy waveform without the possibility to identify single motor units. From recordings with special electrodes, we know that within this pattern here, that there are motor units that are discharging at higher discharge rates than just 10 per second. They discharge 20, 30, 40 per second in healthy muscles. But they are there, but we cannot see them. And this is how muscle force is increased when all motor units are recruited and the individual wants to produce more muscle force output. The individual motor units must discharge at a higher rate. So with high voluntary effort, muscle force is controlled not only by the number of motor units, but also by their discharge rate. Then it's a mixture. With lower force output, only the number of motor units determines the force output. This is the case in a healthy person. This condition is different. We see here the same as here. We see one motor unit. It seems to be small, but keep in mind that the scale is different. So it's exactly the same as in a healthy muscle. 10 per second, one motor unit, nothing special. Here we see the same case as in the healthy muscle. A second motor unit is recruited and it discharges at about 10 per second. From here, we find a difference from healthy to denervated muscle. We see that here we expect the third motor unit to recruit, as it was here the case. We expect this motor unit, but it's not there. Instead, the discharge rate of the remaining motor, of the two motor units, increases. It further increases, line 4. We would expect the fourth motor unit to be recruited, but this is not the case, but instead the discharge rate increases, and it increases up to values of some 40 per second. And this is the case as in a healthy muscle with full voluntary effort. Maximum force output is intended by this individual. But we can now see the high frequency discharges of the motor units. And this is due to the fact that their motor units are missing. We can see the physiological phenomenon of a high discharge rate, and this is good that the motor unit can discharge at a high frequency. That shows that there is no central nervous system lesion. However, the pathology is that we can see we can see the high discharge rates. We can hear them, we can see them. They give you an impression of the sound. This is the characteristic sound of high frequency discharges of motor units of a denervated muscle. Again, it is quite easy to train, to learn to recognize this sound. And it is a very characteristic finding for denervated muscle. The maximum discharge rate of the motor unit has a very close correlation to the number of active motor units in that muscle. And the black dots here indicate patients with a neurogenic disorder. And you see that the discharge rate is correlated with the number of motor units in that muscle. And if the number of motor units is reduced, we found the discharge rate increased. We can also see that the discharge rates increase only if the reduction of motor units is quite significant. So a minimal lesion or a slight lesion of the muscle cannot be detected always by the finding of a high discharge rate. As we said, with spontaneous activity, if it's regular, it's pathologic. For the discharge rates, a similar rule. If it's too high, it's pathologic. There may well be normal pathologic cases with normal discharge rate, but if the discharge rate is found too high, it's pathologic. Here's a warning in red. This picture here holds for limb muscles. In cranial muscles, qualitatively it's similar, but discharge rates are higher. They may be up to 25 per second, such as in sternocleidomastoid. Facial muscles may reach 38 per second until they are pathologic. And it depends on the cranial nerve and on probably on the size of the muscle being studied. So here's one of the differences between cranial muscles and limb muscles. Oops, vanish. Here, the same picture, but not with number of motor units, but with muscle force output. And you can see, again, these black dots are denervated muscles, neurogenic muscles, and the open circles or open squares are myopathic or healthy muscles. And you can see with considerable weakness that the discharge rates increase. And here's the upper limit of normal for limb muscles. It's some 16, as a rule of thumb, you can say 20 per second holds for all limb muscles, but not for all cranial muscles. Some discharge rates or the limits of normal need to be established for cranial muscles. One meaningful point is, when does this phenomenon occur? And this does not depend on the time. So the phenomenon of increased discharge rates accompanies the lesion, the weakness, sorry. It can be found as early as 20 minutes after a traumatic nerve lesion, and it remains as long as the weakness remains. And if the recovery is full, usually the discharge rates return to normal. So there's no need to wait with the EMG, to wait for something to occur. If you want to determine discharge rates, you can do the EMG study immediately upon a lesion. We need to talk about what is called interference pattern, or reduced recruitment, or reduced interference pattern. This is a finding commonly described in many EMG findings, and it's some kind of old-fashioned in my mind. Here you have a picture you're already familiar with, the healthy muscle and the diseased muscle, but both recordings, all 4 recordings, are made, as you remember, at low voluntary effort. So the patient or myself were instructed only to do a very slight contraction, and you cannot see any difference in the discharge behavior. Now, the patient is instructed to generate more and more force output, and we find what we already are familiar with. We find that the discharge rates increase, but as the patient has lost most of his motor units, we can see the increase in discharge rate. Now, in the left picture, we skip these recordings here and think what is happening here when the patient does not provide full effort. And so this will be the limit. The patient will say, well, this is the utmost effort I can produce. Here, he could produce more effort, but he does not do so. What we find here, the patient says, well, it's my full effort, and we find a so-called reduced interference pattern. We expect a pattern of that kind, but it is distinct. The density of these spikes is not reached. So this is called a reduced interference pattern. It is similar as here. There are still parts of the baseline recognizable, as it is the case in here with this patient, but the difference is fundamental. This is a peripheral nerve lesion, and this is lack of voluntary effort. Lack of voluntary effort may be due to some incorporation, non-cooperation of the patient, but it is characteristic for all kinds of central nervous system lesions. So a stroke, multiple sclerosis, brain tumor, they all, if they cause weakness, they will all cause this kind of reduced interference pattern. While peripheral nerve lesions will cause this kind of interference pattern, peripheral nerve that includes cranial nerves. So reduced interference pattern comes in two flavors. One is with increased discharge rates, and this is a proof of a peripheral lesion, a loss of motor units. And a reduced interference pattern may come in this kind, and then it's characteristic of a central nervous system lesion. So reduced interference pattern is an interesting finding, but we need to know the discharge rates of the motor unit to be able to fully interpret a reduced interference pattern. When does what occur? This is the wrong line here. The increased discharge rates are found immediately upon a lesion. As I said, you need not to wait for it. And they remain with the lesion. If the recovery is full, the discharge rates return to normal. If there's a not full recovery, discharge rates may be found increased upon for the rest of the life of the patient. And keep in mind that with a total nerve lesion, there's no voluntary activity. Again, immediately upon lesion, there's no voluntary activity, though it may well make sense to do an EMG immediately upon a nerve lesion, depending on the clinical setting, when we wish to know, is the nerve damp, is it transected or not? Is there some remaining activity? Or is the nerve, or is the weakness caused by CNS disorder? Then we found some motor units, but not increased discharge rates. So here's the timing of the discharge rates. We'll have another point, and then we're through with it. The usual findings, the usual suspects. Here, I talk about the polyphasic motor units. This is an interesting finding and meaningful, but it's ambiguous. Again, EMG in the muscle, all the green fibers discharge, and they will generate potentials of that shape, that kind. Now, after a lesion, repair occurs. The repair, if not all axons are damaged, is called collateral sprouting. If some axons, for instance, this green axon survives a lesion, then the nerve fiber, this one single nerve fiber, will grow sprouts to other muscle fibers that formerly belonged, for instance, to the red motor unit or to other motor units. And those sprouts will try to reach those denervated muscle fibers and will connect them to the green unit. So the green unit will grow, like settlers in the West or so. So if a muscle fiber here, those freshly re-innervated muscle fibers are indicated blue, if such a muscle fiber is reached by the green axon, those sprouts are not myelinated. So the conduction from the nerve axon to the green fibers, as it's myelinated, will take less time than the conduction time from the green fiber to the blue, to the newly re-innervated fibers. So we'll find those late components here as an indicator of re-innervation by collateral sprouting. Collateral sprouting requires that a nerve axon is still present, is lively, is intact, and is able to send those sprouts to the denervated muscle fibers. And this is the process of ongoing collateral sprouting. You see by those late components, also by increased turns, and those motor unit potentials are generally called polyphasic or desynchronous. Polyphasic is a common label for these phenomena. And polyphasicity occurs, for instance, with collateral sprouting. When collateral sprouting is successful, these nerve fibers here, formerly blue, are remyelinated. So the nervous system waits until successful reinnervation of a muscle fiber. And if one of these distal sprouts is successful, it will get its myelin sheath. And then the conduction desynchronization does not further take place. And we find now that the innervated muscle fibers are integrated into the potential. So this potential will grow as now more muscle fibers contribute to the signal, and they do it synchronously. So we have only few or none late components. Again, not many phases, but a large potential. And this is the result of successful reinnervation, particularly by collateral sprouting. So low, not increased polyphysicity, but increased motor unit potentials in late stages of reinnervation. So what do we have here? The polyphagia I told about. The collateral sprouting occurs starts some 6 weeks after the lesion. If you find polyphagia before, you may infer that there has been a lesion before the lesion under discussion or under diagnosis. Polyphagia needs some time to happen, and it takes months, let's say 6 months to 1 year, to vanish and to give place for increased motor unit potentials. And this is the residuum. The increased or the enlarged motor unit potentials will remain until death. One more word on these. What happens if no axon survives a lesion, but the nerve is repaired successfully, for instance, by surgery? Then all of the axons need to grow from the suture towards the innervated muscle. And when those axons reach the muscle, note that all axons have been dead, the first axons reaching the muscle will innervate some very few muscle fibers. And we find some very small motor units, also polyphasic as here. They're called nascent units, freshly born motor units. The further recovery happens similarly to what happens with partial axonognosis. These nascent motor units look like as in myopathy and can be found only very early upon successful reinnervation by axonal growth. Remember axonal growth, 1 millimeter per day. With cranial muscles, it's from a neurologist's point of view, it's quite rapid as it's only a few centimeters in the head. But for limb muscles, it will take months or even up to 1 or 2 years for reinnervation, which sometimes is too long. So this is the final slide here. I've reviewed the phenomena you may find, and these are, except for the differences I mentioned, they follow the same rules in cranial muscles, such as laryngeal muscles, as in limb muscles. And now I would be happy for your comments or questions. Thank you for listening.
Thank you, Wilhelm. Great contribution. I fell back to my study and learned from the basics. Very didactic. Thank you. I have some questions, but first of all, we would like to give the auditory the opportunity to send questions to the chat. And during you are writing your chat questions, I want to start with the first question. Wilhelm, how do you know where the end plate region in a certain muscle is located?
Well, exactly, I don't know. Usually it's in the center of the muscle. It's easy, for instance, here, for the biceps muscle, it's right in the middle. But this is not true for all muscles, and some, especially muscles that are multi-segmentally innervated, such as anterior tibial, have several end plate zones. So from anatomy, I'm not sure where the end plate zone is. When doing EMG, it's very easy to find. Just look at the patient's face And if it's like this, then you have found the end plate zone with the needle tip, as the end plate zone usually is painful. This is not the case. You will find these end plate spikes, very irregular activity that with a clear-cut acoustic shape. You need to study this only a few times, and you will never mistake it for pathologic spontaneous activity. It's the irregular behavior. Third, in the end plate zone, there must be there may be some kind of activity. We call it the end plate noise. That is it's like white noise, but with some bubble character. And again, you should hear this noise from demo recordings, not to mistake it for another phenomenon. And this noise is caused by some acetylcholine vesicles leaking from the end plates that are reaching the postsynaptic membrane and cause minimum changes in the voltage there, not depolarization, but minimum voltage changes that are also recorded by the needle electrode. The end plate noise. It's a rare phenomenon. More frequent, we have the pain, or we have those end plate spikes in the end plate region.
Thank you, Wilhelm. We have one question from our external faculty, from Yakubu Karagama. Yakubu, want you ask by yourself?
Yeah, I've got a couple of questions actually, because the dilemma for us, it's first of all, I'm Yakubu Karagama, laryngologist at Guy's and St. Thomas's Hospital, London. It's really the time that we have to wait before we offer surgery, because as you know, we have 3 options of surgery for these patients. We have injection, we have thyroplasty, we have reinnervation. So there are patients that they have damage from the mediastinum, in which case we know that the distance between the cranium and then the aortic arch and then back to the vocal cord is quite a longer distance. And in such case, do we expect a longer recovery, say up to 12 months or even 2 years? That's one question. And then the next question is people that have got vocal cord paralysis as a result of stroke or idiopathic, again, is longer recovery. I've had a patient that had idiopathic paralysis, and it took after 2 years before the vocal cord function returns actually. And I've had patients from stroke, and then within a few months it recovers. So I don't know if there's any guide regarding that. This will help us in determining whether we should go on with surgery and what sort of surgery we should offer these patients, whether we should just do an injection and wait, or whether we should do thyroplasty, or whether we should cut the nerve and reinnervate it again.
Yeah, this is a kind of very classical question. When to decide whether to do surgery or not. I suggest, or I think you mean a paralyzed nerve, a nerve with a total damage, and you need to, or you wish to decide when to repair this totally damaged nerve, or when or if, right?
Yeah.
With a short distance between the lesion and the muscle, it's quite easy to say, well, let's just wait. It's 1 millimeter per day. So if it's 8 centimeters, it's 80 millimeters, you wait 80 days. And if there's no recovery, there won't be recovery. Give it 80, 90 days. And there will be plenty of time for the nerve to regrow after successful surgery. The question is quite difficult with muscles way apart from the system. Imagine a hypothenar, ulnar nerve. This is much more than 1 meter, and it will take, for recovery, 1 meter is 1,000 millimeters, will take 1,000 days. After 1,000 days, that is 2.5 years, the muscle is already destroyed. So you need to decide earlier as to just by wait and see. The decision whether to do a repair is critical with the distance, and it depends on the nerve or on the site of the lesion. One method could be to do, if possible, to do an ultrasound of the damaged nerve if it can be reached by ultrasound. This is typically true, except for instance, for the ulnar nerve. You can see the ulnar nerve very, very well in the ultrasound, and you look with the probe to the damaged region. If you see the nerve is transected, you know already you must do a nerve repair surgically. And as soon as you know you must repair the nerve, you must do it. Then no waiting. Very difficult question. If the lesion cannot be seen via ultrasound or high-resolution MRI, when you see that there is no action potential, that all nerve fibers are damaged, it may well be the case that the nerve is damaged. And if it's crucial, probably it makes sense to explore the damaged site and look for the nerve. And there are some centers who do intraoperative nerve conduction measurements. So you dissect, you do surgery, look for the nerve and do a nerve conduction study on the damaged nerve. And if the condition is, if the nerve conduction is totally blocked at that time, you do a nerve repair right now within the same surgery procedure. And if you see there is nerve conduction at the damaged site, you just close the wound and wait, and there's good chance that there will be a recovery. So grossly, if there's a short segment between lesion and nerve, wait and see is good. If it's a long distance to be, if there's a long distance between the lesion and the muscle, you must individually look, but the decision must be made as early as possible, as the time window is only some 12 to 18 months. After that time, the muscle fibers degenerate and renervation won't help.
You know, you mentioned about the regeneration of the damage to the muscle. This has been a huge controversy for us during the laryngeal innovation. And we did a multi-center study not long ago, and the bar that we've set is if the injury occur within 2 years, and then we've moved it to 5 years. And the reason is because some ENT thinks that there is rarely such a thing that the muscle is completely dead or fibrous, because there is almost invariably some synkinesis, some degree of supply from other nerve that keep the muscle alive, but not sufficient to make move. And some of us have done re-innovation in patients that have had paralysis. The longest I've done is 5 years, and we found that actually the muscle tone has restored. Jean-Paul Marie said he's had it in a congenital patient with vocal paralysis, and then he re-innovated, and then he found that there's a muscle tone recurring. So this question is waiting, and whether the muscle would degenerate, again, is not very clear cut. So I don't know if you can expand on that, or is it different from the laryngeal muscle compared to the muscle in the limbs?
Well, you mentioned a phenomenon, the synkinesia, that practically does not occur in limb muscle. Of course, neurologists are very familiar with this phenomenon in the facial muscles, but we're not that familiar with laryngeal or other cranial nerve muscles. So synkinesia may lead to clinical dysfunction, although the muscle is not totally denervated. When the muscle is denervated, I think, I'm not sure, of course, but I think there will be irreversible degeneration also in cranial nerve muscles, as we can see, for instance, in the facial nerve. If the facial nerve is totally damaged, the facial muscles degenerate unless they are cross-innervated from the healthy side. But if there is no reinnervation, a muscle will degenerate. The synkinesia may fake, in a way, fake denervation, as it may cause immobility of the muscle, although the muscle itself is not denervated. And of course, in this case, if the muscle is not degenerated, nerve repair could make sense, even after years. So my remarks were on totally denervated muscles. And I feel that is the same for cranial muscles as for limb muscles, but only if they are proven denervated.
Thank you, Wilhelm. I think you are right. This is only a rare condition that, but it occurs in some cases that we have really a denervation. But in the majority of the cases, we have some kind of resting innervation, of foreign innervation or synkinetic reinnervation, as we call it. And therefore, maybe late repair or late nerve transposition can help, so we think. There's another question from Kathleen from our group. Can you explain the persisting spontaneous activity? How does this work?
Well, at first, probably I started with a description. We found this persisting spontaneous activity in a patient who was referred to us during an EMG course, teaching course. And this patient, for instance, got his lesion during World War II. The course took place only a few years ago. And this patient, despite recovery, partial recovery of his lesioned ulnar nerve, this patient still had spontaneous activity in the partially recovered muscle, partial recovery. Just as an example, my personal explanation is that a muscle fiber, if denervated, starts to generate or to produce spontaneous activity, for instance, with the purpose to attract nerve fibers. It cries for help, please reinnervate me. After some time, if there's no reinnervation, this muscle fiber degenerates after some times. And we do not know when this will take place. It's kind of in radioactivity, it's an exponential decay. Several muscle fibers degenerate early, some muscle fibers degenerate later, and obviously some muscle fibers never degenerate. They never stop crying for help. And this is this persistent spontaneous activity. It's not abundant, it's few, and it gets less over the years, but it may persist up to 50 years or so after a lesion. It may.
Thank you. One question from our clinical point. We use since 2017 a surgical method where we insert an additional nerve in a, let's say, synkinetic reinnervated muscle. So we are not fine with the position of the vocal fold. We are not fine with the function of this larynx. And therefore, we think if we cut the nerve and perform a totally new reinnervation, the patient can lose some of his function, but he needs some better function. So therefore, we insert an additional nerve into this muscle. What do you think as a neurophysiologist? What will occur inside such a muscle?
Well, I have no experience, of course, with that procedure, but in theory, it should work. It requires that you dissect the supplying nerve of that muscle you wish to reinnervate. So if you insert a new nerve segment into an already innervated muscle, nothing will happen. You need to denervate muscle fibers to make them cry for help, to induce reinnervation. So cut, and was I'm understanding right, you cut the nerve that innervates the muscle today, and instead insert a new nerve segment or introduce a new nerve segment into that muscle. So both, in my mind, both is necessary to induce reinnervation. If you do not cut the original nerve, yes, the new nerve segment will never reach some muscle fibers for reinnervation.
So this is the theory, and what we do is that, of course, we result in a muscle lesion, and maybe we destruct some terminal endings of nerves during the insertion of the new nerve, but we still let the, let's say, old nerve in place. So from theory, it should not result in any improvement, but in reality, in younger patients, we see it works. We don't know why.
Okay. Maybe another explanation, if it works, may be that there are many muscle fibers that are still denervated when you insert the new nerve. And these muscles, the denervated muscle fibers, of course, may attract the new nerve fibers for renervation. That could work.
Thank you. That's what we think.
Okay.
Are there other questions, Gerhard? Do you have a question? No. Oh, okay.
I have one comment. So even if all fibers would be renovated, some of our fibers in the face or in the larynx have more than one synapse. So perhaps not all end plates are already blocked. So the renovation could perhaps occur by the double innervation, triple innervation. So we can perhaps boost an already mostly innervated muscle.
Well, this is an issue. I'm a bit skeptic whether this frequently occurs, the double reinnervation of muscle fibers. I never found convincing evidence for this phenomenon, that there's a multiple innervation, that one muscle fiber is innervated by multiple motor neurons.
We don't need to explain it, because the other, your theory is better, that just part of the muscle is innervated and part is still denervated, and when supercharging it with another nerve, then the denervated part get innervated. So we don't need a more complicated model. Thank you.
Well,
Wilhelm, we will skip this session. You are welcome to join the course, and you are also welcome to comment and to share our discussion. And we want, after this perfect introduction to our course, we want to go to the part where we give an instruction, how we do it, how we perform laryngeal EMG and how we interpret it. And we will start with a contribution from Berit from Vienna. So I give you the program. So this is where we are. So thank you, Wilhelm. And we go now to the laryngeal EMG instructional course.
So this is an old team we know since a few years. Unfortunately, this year, due to COVID-19, we are not able to meet all here in the same room. And even Berit and Claus, for short notice, have problems to in the hospitals to they can't give their talks here live. So we will fall back to some pre-recorded things. So first, Berit will give an overview how to put needles in the larynx, transcutaneous to the TA. Then Gerhard Förster from Gera will give a talk about how to get to the PCA muscle, and also how to interpret these results. And finally, we will have a video from Claus Pototschnig from Innsbruck showing us the transoral ways to both muscles and what we can do with it. And after these three important talks, I will give a short summary of what these techniques, how these techniques can be used. Normally, I also bring some electrophysiological background. This was already very well covered by Professor Schulte-Mattler, so I will just use it as a repetition or sum up, but we will be very short and limited. We will start with Berit's talk. Thank you very much for your audience. So the talk from Berit will describe how to put the needle transcutaneous into the larynx. how to use it also from the outside.
Geht. Ich finde sie nicht in den freigegeben. Sorry, we have to change the screen.
Just, yeah. We are happy to be here in Jena in a conference room, what is more or less hybrid capacity. So we are able to sit to each other and use one laptop for the presentation, but on the other side, this has sometimes a problem that the person on the hot chair has to handle it. And today, Andreas has to give the playbacks. So I think in the future, this hybrid could be something very useful for rare diseases and rare questions like these, because otherwise I think it could be difficult to invite someone from the San Francisco or even from Regensburg here to give this brilliant talks. But in the future, it would be also nice to have people around. So both could be an improvement we can take out from Corona to not do everything by Zoom, but perhaps in the future combine some experts, bring in guests from all around the world, but also bring in speakers who have very specific knowledge, but it's not too easy to gather otherwise. So it's challenging to do hybrid sessions, and we still have to learn a lot about it. But I think especially for us as this small community, it could be a great opportunity. So now we start with Berit Schneider-Stickler from Vienna.
Great pleasure to join this webinar on neurolaryngology, and I'm very happy to present the transcutaneous laryngeal EMG here in this webinar. You can use for transcutaneous approach concentric needle electrodes, either monopolar or bipolar, and of course you can also use the hooked wire electrodes, which are not that easy to place, but with experience you can get very good results even with the hooked wire electrodes. I would like to start with an example on the transcutaneous approach with bipolar concentric needle application. You see here an LMG examination with a patient with a unilateral vocal fold paralysis, and the electrode is placed in the TA muscle. Schön laut. Und nochmal. Okay. As soon as you entered the needle into the TA muscle, you follow the sharpness and the sound of the activation potentials of the muscles. And when you have the feeling that the needle tip is in the right position, then you start with giving the instructions of either resting, sniffing, or phonation, and then you follow the signal on the LEMG device screen. We have two problems to deal with during performing an LEMG examination. One is a coughing reflex and the other one is pain. We treat our patients before the LEMG examination with codeine drops. We give approximately 20 drops half an hour before performing the LEMG. And to reduce the pain for insertion of the needle, we use local anesthetics. You can use either prilocaine hydrochloride or lidocaine, and you inject this in the subcutaneous tissue in front of the larynx. Sometimes you can even enter the thyrocricoid membrane, and you also do the injection into the air column, into the trachea, to reduce the coughing reflex and also to reduce the pain, especially if you would like to perform a LMG examination of the PCA muscle. The position of the patient can be either supine or he can sit in an upright position. So it's up to you how you do the positioning of the patient. For entering the larynx, I recommend to follow the recommendations given by the Neurolaryngological Working Group guided by Fabian Volk. And if you follow these recommendations, then you can easily find the respective muscles, either the cricothyroid, the CT, or the TA muscle, or LCA, or PCA. So this is by palpation, by inspection, and of course by knowing the anatomy of the larynx. Sulika and co-workers published recommendations for the transcutaneous approach, and you can see here that you have 3 different options to do such a transcutaneous approach. You can insert transthyroidally, you can insert from above the superior notch of the thyroid cartilage, or the most recommended one, you use the cricothyroid membrane to enter the larynx from the anterior part, from the front. The transcutaneous approach from the front follows, especially here marked with the skeleton of the larynx, by localization of the superior notch of the thyroid, the lower edge of the thyroid cartilage. You try to palpate the cricoid, and if possible, you also try to palpate the lateral edge or the superior or inferior conus of the thyroid cartilage. And when you have an idea on the anatomy of the larynx, then you can enter the larynx with your needle. In this patient, the anatomy is quite easy to estimate. It's very easy to see the superior notch. It's very easy to palpate the cricoid, the thyroid, the lower edge, and then it's easy to find the cricothyroid membrane if you would like to do the LMG from anterior. If you would like to use a lateral approach, what sometimes is important for doing examination of the PCA or even of the upper esophageal sphincter, then it is you have to rotate the larynx to the opposite side so that you can enter the larynx from the posterior wall or maybe from the lateral part of the larynx. I would like to show you some examples from an abduction, because sometimes it is not that easy to even localize the PCA or the LCA complex. If you enter from anteriorly, then it is quite easy to reach the TA muscle. If you insert more inward, then of course you can reach the TA and the LCA complex, but it is very complicated at the beginning if you start doing the LMG to reach the PCA. As long as the PCA is working properly and you get signals, then it's quite easy to say, yes, I'm in the right muscle. But if you have a silent LMG, then you can rely only on your positioning of the needle by knowing the anatomy. And that's why I would like to show you here how important it is to estimate the right angle for insertion of the needle. if you go a bit to, if you go up in the larynx, then you do not enter the PCA, you might enter the IA muscle, the interarytenoid muscle. And this is not the muscle you would like to reach with your needle. So be aware to positioning the needle more downwards. If you come from the front, more downwards, so you enter the PCA to rely on the LEMG signal you get on the screen. The evaluation criteria for the EMG examination are the same like already Fabian Volk introduced to you. We observe if we can hear or see any insertion potentials. Then we evaluate the muscle activity potentials during resting, including the evaluation of any spontaneous activity. And then, of course, we do the examination of agonistic and antagonistic activity maneuvers to get the right LEMG signal. I would like to show you another sample, a transcutaneous approach with hooked wire needle application, and please, the film can go on.
Ganz ruhig bitte atmen, ganz ruhig. Und mal ein. Und nochmal tief einatmen. Und ruhig weiteratmen. Und nochmal schöne A's bitte. Und zwischendurch ruhig atmen.
In this patient, you could see that there was quite strong activity even during the antagonistic maneuver of the TA muscle. So that means that in this patient, we evaluated the signal as being synkinetic reinnervated. Sometimes the patient does not present a perfect and easy anatomy. Even in these patients, you can see here with the hematoma or even with the tracheal tube, sometimes you have to do the LEMG. And even in these patients with quite good experience, you can perform a reliable LEMG examination by transcutaneous approach. With these two pictures, I would like to thank you for your kind attention, and if you have any questions, then I will be happy to answer these questions. Thank you very much. Dear colleagues, it is a great pleasure .
So thank you for Berit for your talk. Unfortunately, this is no longer around, so he's back in the hospital. But if you have any questions, I and the faculty will try our best to answer your questions. Feel free to unmute you and also use your camera so that we see you.
Du machst den Ton, ne? Oder wer macht den Ton?
Ton ist an, aber Kamera habe ich nicht ausgemacht.
Kamera bist du ja noch anmachen, genau. So. Any questions from the audience? I think due to the small group and it's okay to use your camera, use your microphone. Yakubu was asking for codeine, but yeah. Yeah, I think oral codeine works very well, but yeah. I think that's also the way Berit is doing it a little bit in advance.
Codeine oral, is it orally she gives the codeine?
Yeah, as far as I remember.
Wondering why she goes for the drops, not just the tablets.
Yeah, good point. Okay. No, sorry, I don't know. But we will ask her later. So the next talk will be live from Gerhard about PCA EMG. So that's partly the technique, how to get there, how to get the signals, but also how to interpret the EMG and what's special about this muscle, because it's special, and Gerhard is one of the few people who has very much experience with this muscle, because he tries to get these recordings as often as possible. While most other people doing larynx EMG are often happy if they get the TA and then don't go further if they have results from this muscle. So perhaps we should look a little bit deeper. Perhaps we should see what extra results Gerhard gets from going to the PC.
Yeah,
You have the word.
yeah, dear colleagues, good afternoon. Thank you for giving me the chance to say a few words about the EMG of the posterior cricothyroid muscle and what I think is a bit special about it in comparison to the TA, which more of you may be familiar with. So the first question would be why to do the PCA EMG? And here, again, those of you who have done a few TA EMGs may have noticed that there's a considerable number of patients which have a complete vocal fold immobility, but who have a normal or a near-normal appearing EMG of the TA. So in those patients, you would not be able to give a proof of an RLN lesion just from doing the TA EMG. And if you do in those patients, if you do a PCA EMG, you most invariably will see a highly damaged PCA. So this is especially the case in iatrogenic lesions. And if you compare the interference patterns of TA and PCA, then you might see in many cases kind of a preferential damage of the PCA. And later on, if there's some recovery, some regrowth of the nerve, you may also pick up in the PCA differences in the pathologic reinnervation. So this is another course why you might be interested in taking a look into the PCA on a regular basis, which I would highly recommend you. So how do you approach this muscle? Berit has mentioned already a few words about it. There's basically from the transcutaneous, on the transcutaneous route, there's two ways to do it. There's the classical lateral approach, which is a bit more difficult and a bit more painful in many cases, but may have advantages if you use it for botulinum toxin application, since you do not have to penetrate any cartilage and you may not have, therefore, any possible needle blockage. So, but to achieve an entrance of the needle via that route, you have to manually rotate the larynx to the opposite side to be able to identify the posterior border of the thyroid lamina. And then you have to navigate your needle around it. It helps sometimes to bend the tip of the needle to get better around it, but it can be quite painful as you scratch the perichondrium. So I don't like this method very much. I think most of us today prefer the so-called midline approach, where you palpate the cricothyroid membrane and you then enter into the subglottic airway and reorientate the needle slightly about 15 to 20 degrees to the side, and then penetrate the thyroid lamina into the underlying PCA. How to define the height of the needle? That's an important question. There has been some work done by an Austrian group, but they used isolated larynges and used this line, the anterior border of the thyroid cartilage to orientate, but this is not exactly what you have if the patient is sitting in front of you. So as a rule of thumb, I would recommend to you that you use a more horizontal orientation of the needle as compared to the skin line. And in male larynges, which are high, you should slightly orientate the needle slightly upwards. And if it's a narrow female larynx, you might rather orientate the needle a little bit downwards. And as another rule of thumb, the thicker the cartilage, the better you are. And if the cartilage is really thin, it's often a sign that you are a bit too low. So the next question, what needle to use? It's a bit philosophy of the examiner. So a stiffer needle like 23 gauge, 70 millimeter, offers you a better control of the needle, and also it's easier to penetrate the cartilage, especially if the cartilage is very ossified. It's easier to use a thicker needle, but patient comfort suffers a bit from it. So in some cases, you might consider using a thinner needle like 26 gauge, which offers better patient comfort. So I often stick with the real thing, with the 23 gauge needle. So here's a small video example showing our setup. So you palpate the cricothyroid lamina and penetrate it. Then you can hear a brief air sound. My sound, am I audible or not? So as soon as you penetrated the cartilage, you pick up the signal. In this case, a highly polyphasic signal. I usually allow a few breaths of quiet breathing, and then I start with the maneuvers. The forced sniff as an agonistic maneuver. And you have to look for the highest density in this. And then I use phonation as the antagonistic maneuver. And usually during phonation, there should be silence. So in this case, there is a pathologic reinnervation. And in the end, I let them swallow twice, which is also an antagonistic maneuver. So since you cannot really see the tip of the needle, you have to rely on the signals for the placement control. And you do an agonistic and an antagonistic maneuver. So with the agonistic maneuver, the activity should increase. And with the antagonistic maneuver, strongly decrease or cease. So that is very important. To a way, I haven't mentioned, sometimes you can use the aid of a flexible laryngoscope to monitor the needle as it passes through the subglottic space. So the background or the baseline of the PCA-EMG is usually not as quiet as in TA-EMG. There's always kind of an undulating baseline. And this background noise is usually not end plate noise, but it's usually from the cricopharyngeal background noise from the neighboring cricopharyngeal muscle. And we know that because usually this noise ceases if the patient swallows. then the baseline becomes a flat line. So in normal or near normal PCA EMG traces, you are not able to see the baseline during normal respiration, and you will not be able to see small amplitude signals. To see them, so to see those signals, you have to do an antagonistic maneuver, so let them phonate. And if you let them phonate, then you see the baseline and also any possible small amplitude signals, like in this case, where you have some pathologic spontaneous activity interspersed in this signal. One has really to look for it, but as we have learned, you have this high periodicity, the high regularity of these signals. The signals have a characteristic size in the PCA, and they are more pointy than the more rounded background noise. Next, I have a few examples for you of typical pathologies that we often encounter. The first is a fresh and acute recurrent laryngeal nerve lesions, where you see that there is no muscle, no voluntary activity during phonation, just the background noise. In a chronic lesion where some pathologic reinnervation has occurred, there you see antagonistic or synkinetic activity. Formerly, fibers innervating the TA have grown into the PCA and are active during phonation. These motor units are usually smaller than the native ones. And in some cases, so up to 20–25%, you have a more constant activity with only very little changes during inspiration and phonation. And we are not really sure what this activity or where this activity comes from. And we think it's some aberrant reinnervation from the neighboring CP. And there are some cases where we can't really tell where this pathologic reinnervation originates from. Lastly, here are a few examples from the swallow maneuver. As I said, during a swallow, usually during the swallow, there is this smooth baseline, as you can see here. But quite often during the swallow maneuver, there's a mid-swallow burst, which occurs in healthy people. And in chronic lesions with synkinetic reinnervation, of course, there's also activity throughout the swallow. So synkinesia can be seen during the swallow. So I want to thank you very much.
Thank you very much, Gerhard, for this very unusual, very special talk. So it goes far more than just a technique, but really very interesting interpretations of where the signal could come from. And I think it's very, very special, these different patterns, and so your suggestion that it could come from muscles close by, but not everything is yet solved, and it could be difficult to get closer. How would you recommend to answer this question? What would be ways to know about double needles, triple needles from different muscles and compare the activity patterns?
Well, actually, we cannot really be sure. It could also be that maybe the PCA is just simply so atrophic that you're picking up both muscles at the same time. Yeah? So, but what I can definitely say, you don't see these constant activity, which only ceases during the swallow. You don't see that in fresh lesions. So either it's atrophy of the PCA, or it's some collateral or aberrant reinnervation. It's difficult. You would need to do double trace studies and look at brains. Yeah. Otherwise, it's really difficult to actually prove. Yeah. Yeah. And I wouldn't allow anyone allowed to do that in me. Yeah. So, most certainly.
No, for sure. Yeah. Any question from the audience? We have time, so feel free to ask. Otherwise, we will go further with a talk from Claus Pototschnig for this not live, for this presentation from recorded previously, but one of his colleagues is as a representative from Austria.
Again, welcome to our webinar Neurolaryngology. In the following, I would like to introduce the technique of laryngeal EMG. Here you can see the muscles that can be examined in the laryngeal EMG. The most important muscles are the vocalis muscle, the TA, as the representative of the adductors, the posticus, the PCA, as the only abductor, and the anticus, the CT, as the target muscle of the superior laryngeal nerve. In laryngeal EMG, we distinguish between different access routes, endolaryngeal or transcutaneous. Recording is performed with bipolar or monopolar, hooked wire and needle electrodes. In addition to arbitrary activity and spontaneous activity as a sure sign of degenerative damage, like in axonotmesis or neurotmesis, also electrically or magnetically stimulated potentials can be recorded. The advantage of endolaryngeal recording is exact positioning of the electrode under direct view and good fixation. Disadvantage is the time-consuming examination. The change of electrode position is not possible, and we have increased stress for patient and increased costs. The transcutaneous recording allows variable positioning of the electrode, is less time-consuming, has lower costs, and reduced stress for the patient. Disadvantages are uncertain recording, specific and atypical potentials, unstable electrode fixation, and a higher risk of bleeding. Here you can see the application set for an endolaryngeal recording on an awake, locally anesthetized patient. The following video shows a complete examination procedure in a patient with bilateral vocal fold immobility. After local anesthesia, under endoscopic control. The hooked wire electrodes are positioned on both sides.
Sehr schön, ganz ruhig bleiben.
During the EMG of the TA, this patient has activity in both functions. Phonation and also during inspiration. This is a sure sign of defect healing in the sense of autoparalysis. The examination is also possible on a ventilated patient, for example in children. After positioning the electrodes, the measurements are performed on the patient during the wake-up period. For the examination of the awake patient, we prefer a 4-channel recording. Laryngeal EMG, breathing belt, microphone and thermistor allow an accurate assessment of breathing and phonation phases. Starting on the immobile side, the patient performs 3 phonations and 3 rapid inspirations during recording the TA. For the PCA, it is performed in reverse way. The healthy side is then examined in the same procedure. In the following, you will see clear activities with phonation, with bilateral vocal cord paralysis and recording of the TA. But in the next slide, activity can be recorded at inspiration too. This is again a sign of defect healing in the sense of autoparalysis. We see an autoparalysis in 80% of the cases. This is explained by the type of regeneration. The majority of the damages can be shown as mixed damage. In this form, with parts of neuropraxia and axonotmesis, there is a mixing of fiber growth to the adductors and to the abductor during regeneration as well. This finally leads to a tight paralysis. For this reason, the prediction reliability for a complete recovery of movement is very low, since even small amounts of degeneratively damaged nerves lead to autoparalysis. In contrast, the prediction reliability for an autoparalysis is almost about 100%. Finally, I would also like to draw your attention to LEMG website, which contains further information and tips about LEMG. Many thanks for your attention.
Achso, Entschuldigung, habe ich das gemacht? Sehr geschickt. Das wäre natürlich. Was für ein Key? Ich euch rausgeschaltet. Sorry, we still have to learn. I've muted us, and as a host, he can't unmute himself as long as I've muted him. Sorry. We're still in a learning curve. Thanks to Innsbruck, thanks to Klaus for this talk. And does the audience have any questions to this talk? Is there anything we can immediately answer? Feel free to use the chat, raise your hand, use your camera and your mic. If there are no questions, then I have 15 minutes to talk and give a sum up, and what will be a very detailed sum up. So be careful not to give me too much time, but I'm happy about it, of course. So I will share my screen and try to give an overview. Because of our guest speaker, Professor Schulte-Mattler, some of the basics are very well covered. So I only try to go into the details special for the larynx. But before we go into all these details, we should raise a question: what for do we do larynx EMG? Is there any scientific proof that it's useful to put needles into larynx? Of course, all of you should know, otherwise it would be a waste of time to be here. But anyway, it's perhaps worth to look into the evidence. And the evidence is not so bad. It's much better than in many other techniques we do in routine. But some people have done good studies. And here's even a meta study comparing several studies. So here are the studies summed up. So in total, over 500 patients included. And the interesting result is that if we sum up all these, there's a high predictive value, about 90%, to give after larynx EMG to discover which patient get a pure prognosis. So putting needles into the larynx can help us to identify the patients with a pure recovery. Otherwise round, it doesn't work. So it's at least in most hands, it doesn't work. So 55% is more or less throwing a coin. So we don't know after the EMG if there's a good chance of recovery, but we know in some cases that there's a bad chance. And due to the talks we already have heard, we know that this is mostly because of the pathologic spontaneous activity or the absence of any volunteer activity. So if there's completely silence or even worse, pathologic spontaneous activity, but only occurs after 10 to 15 days, then we can tell this patient, unfortunately, it's a very unlikely that you ever recover completely. Has this any value in a clinical setting? And there's a great study from Rosen and Johnny Engel, also done in Pittsburgh, and they were doing a prospective study looking for 50 patients who had the indication for a larynx EMG, but they didn't do the larynx EMG immediately. Instead, they were first doing a completely workup with scoping and history and making a decision about the diagnosis and about the treatment plan, and then doing the LEMG blinded, and then comparing what the LEMG was giving extra. And the very interesting finding was that in 10%, the diagnosis was changed. So in 5 or 50 patients, they found new explanations for the vocal fold immobility. And in over 30% of the patients, they changed the treatment plan by speeding it up, eliminating observation times, increasing the observation times only in 2 of 5 patients, or at least go a little bit faster. So mostly they were going fast forward because they were knowing, oh, this patient has a bad chance of recovery, so we can directly go for injections. So there is a use for it. So Professor Schulte-Mattler has shown us a lot about the larynx, but and also has shown a very nice model about how the muscle can regrow. But anyway, I will show this as a repetition helps you. So after a lesion, the distal part of the axon always disintegrates, and if the damage is strong enough, but also a little bit of the proximal part, then there's a good chance that the axon starts to regrow. This is different to the brain, where there's little chance of regrow in the peripheral nerve, and especially here in the face and in the larynx, where the distances are short. There's a good chance that the nerve by 1 millimeter per day has a chance to reconnect to the muscle fibers. If it takes too long, like on the legs, on the arms, the muscle atrophy is for most of the time faster, so the muscle is already gone before the nerve regrows. But from the lesion side, there's a good chance of a branching. So instead of 1 fiber, there can be 2 or 3 or 5 fibers going like trees. So if you cut a willow tree, new fibers come out and try to regrow, and these new fibers can go into different directions and innervate different muscles. That was what Gerhard was already showing us. But there's also this terminal branching. The polyinnervation was already shown by Professor Schulte-Mattler. And here are some histological pictures, all already from 1944. The upper left shows the normal innervation, and after a reinnervation, you see that the different diameters of fibers are visible. And one nerve, having reached first, is growing on and tries to double or triple innervate, and tries to find different undenervated muscle fibers and innervates them. So it looks very similar to what we have seen. Already seen this and better. So this is a personal opinion of mine that we shouldn't use the term paralysis, what means a completely denervation too often, because as long as we haven't put a needle in, we actually don't know about it. And paresis, as the opposite, it always means that there's a little bit left. But in most cases, before putting needles in, it's unclear. So it's perhaps better to talk about palsy, because this is indefinite, or just describe it like hypermobility or immobility. That's in contradiction to this proposal for the nomenclature, but perhaps a good reason to do a review of this paper. EMG needles, we already have seen how to put them in. That's like the EMG machine looks like. We would recommend to use at least a 2-channel EMG, different needles we have seen in the talks. And here now we go into the muscle. My muscle is a little bit more honeycube stay, not so nice histological pictures. Here's one axon growing in motor unit. For sure, you see where I got the idea from this illustration from Schulte-Mattler. Gave his talk a few years ago on a neurophysiology symposium, and I was saying, okay, I definitely need something like this. And here you see every time the axon is firing, all the motor unit is contracting at the same time. Here another motor unit, and here a third one. And now I want to show you what happens if you put the needles in different areas. First, by putting in the needle, you get some insertion activity. That's something triggered by the needle. And that's very helpful, because if you put the needle in the larynx, you can also hit some fat, you can hit some cartilage, and this is physiologically silent. Only if you hit muscles, you get this activity. That's a small zzz, and that's very helpful, so you know now you are in. It looks like this. So now the needle is somewhere, and depending on how strong the patient is activating, you get a little bit activity. Then the interference patterns can go more dense, then it looks the same, but more discharge per second. Then another motor unit jumps in, perhaps on another side, so it can be negative or positive, and even more, and then it looks like this. So it's always a sum of how many fibers are firing in the field of recording. But instead of changing the activity pattern, you can also put needles in different areas. And that's very tricky because you never know where your needle is, and you never can place an EMG needle at the same area twice. So it's likely that you get something completely different by another position. That's how we can do it. Special here is that here's the EMG, but here's also a microphone. You see here the red thing and a chest belt. So for reviewing this recording, it's nicer to do it that way, because then you don't have only the EMG, but you also have some reference signal, so you know the patient was trying to speak, the patient was trying to sniff at that moment. Voluntary activity we already have mentioned. This is the second thing you should put into the your consideration. And now the third one, what's very important, is about the lesion. So if there's a lesion, if the all the axons are cutted, then this pathologic spontaneous activity occurs, and the nerve fibers are no longer the source of activity, but the muscle fiber itself has this pattern, this tuck, tuck, tuck. And so the EMG can record something very rhythmic. So as mentioned in several talks now, and best explained by Schulte-Mattler, we have this completely rhythmic patterns. But it's very nice to see here or here, because there's no interference pattern what goes in. But we can also, so now to see if I have sound. It's very slow anyway. You can listen to it on the website. It's also on YouTube. So, but you see these patterns here. This is for sure super rhythmic, super synchrony. So this is not from the brain, but from denervated activity. Here's a discharge pattern now triggered by the needle, and it's a complex repetitive discharge, some rotating. And we have a good chance tomorrow with a pick to get this activity, because by putting enough needles into the larynx, the small larynx muscle, you can trigger this activity. How does it happen? Most likely by muscle fibers activating each other, so a circulating activity. So pathologic spontaneous activity as a third thing, and then the last thing, this synkinetic, what is perhaps a bad term, aberrant, perhaps better, renervation pattern. So if there's a lesion, if the opening muscles in green or the closing muscles in blue get denervated, luckily there's a good chance of renervation occurs, but by this renervation, there's always the risk of aberrant renervation, so that muscles who were actually only activated by opening are now also closing, and the other way around, closing muscles are now opening. So it's like a tug of war. So they pull in both directions at the same time, and the result could be a hypo or even an immobility. And by EMG, we can partly prove this. We could put a needle in, for example, in the PCA, and here by having a sniff in the first activity, that's okay. By a sniff, there should be activity, because it's the opening muscle, but by the phonation, there should be a relaxation of this muscle, but there was even more activity here compared. So that's very likely that this muscle is partly renovated by fibers for the TA, for example. So this is the last thing we can put in here. How to document all this information? There's a one-pager, a sheet you can download from lemg.org, or you can send me an email and we can send you the Word document, how to go through all muscles, all maneuvers, and stay at the end anyway on one page for your documentation. So this was pictures from the before Corona time. I hope next year we can stay close to each other, and we can again meet in conference rooms. We will see, but I also hope to keep the online channels open, because I think this is a big chance for us. Also, these rare disease networks like the Thuringian or the GranioNet can help us to talk about these special diseases and bring the experts together online and in real life. Thanks for your audience. Any questions to my talk? Any questions to the whole session? Because now we have done a lot of theory, and next would be practical examples, not live, but yeah, live from recordings from patients Kathleen will present. But first, perhaps some questions. No questions from the audience? So
we don't see in the chat questions. So I think over the time you're a little bit tired, so we will wake you up with clinical practice, and Kathleen from my group will present you our workup in the voice clinic and a first LENG case. And she is very experienced also in the LENG and in laryngeal ultrasound. So Kathleen, please.
Thank you very much for the welcome. My part in this session is only to show you some patients and introduce them, and actually doing live ENG, as Fabian already said. Unfortunately, we can't do this at the moment, but we decided to bring you some case presentations. So before I start doing that, I brought you a workup from our clinic, which I would like to start with. Der will irgendwas installieren. Zoom, Audiogerät. Wenn die Audioübertragung installieren Sie das Zoom-Audiogerät?
Nein.
Nein.
We just check our technique. So do you have a question to the indications of laryngeal EMG in laryngological cases?
To wake you up a little bit, we could also start some questions, because we want to learn a little bit from you and to see how many are really around. Mm-hmm. So who has performed an LEMG before and how often? So first answer, never, only watched, seldom, 1 to 5 EMGs in total, some 6 to 50, often, more than 50 EMGs, regular, every month. So we would be very interested to learn from you to get our audience a little bit better into the focus, in our focus. So you can also already go on as you have done. Did you use the pre-course material? So I've sent you around an email last week, but yeah, I'm happy that at least some people have found this email. It will be available even in the next weeks. I think last time we haven't stopped it for the whole year, and we have just ended a week ago. So feel free. So instead of handouts, you can use these videos. What do you want to learn from us? Indications for LEMG. How to do LEMG, how to interpret LEMG. That's a top scorer at the moment. 80% of you, 88% of you want to learn how to interpret LEMG. Mm-hmm. Diagnosis of vocal fold palsy. Treatment of vocal fold palsy. Okay, that's good, because this is definitely not our main focus. How to treat it. That's really more a diagnostic, and yeah, only a little bit goes into the direction of treatment. And so even sonography of the vocal folds. I'm happy about this, because that's something unusual at the moment, but very promising. It's not easy, but I think for the future we have good. We should keep playing with it. Kathleen can do amazing things already with it. Tomorrow we will have an ultrasound machine with us, so there's a good chance that we can, the participants around can already do it. There's one question from the audience. How early can we do EMG after a renovation? You can do it immediately. Question if it's useful.
How early you can do an EMG?
Perhaps the question is more how early is it useful?
After renovation.
After renovation, yeah, this really depends
on the
renovation distance and timeline. But if we have done an unselected renovation, we have seen early renovation potentials, so 4 to 6 weeks after, yeah. So because the distance is not very long.
Yeah, so it's okay to do it early, but don't do it too early. Otherwise, it's just a waste of time. And then, of course, in the time course, it's interesting to do it to perhaps get a little bit earlier first signs of renovation. But it doesn't change anything, so it's not necessary.
No, can I make a comment on that?
Yes, please.
Yeah, I normally will do that at least 6 months or maybe even 12 months down the line, because it's a very painful. It's a painful test, and if you do the EMG, say 3 months or 6 months, if there's no signals, then what? You're not going to do anything. We all know that we wait up to 12 months before you know whether your operation has worked, and then after that, if the patient's voice hasn't improved, if you like, you can do an EMG again. But what are you trying to gain for the EMG? Are you going to do another renovation again if there's no signals? So if you do the EMG, at least it will confirm that it has worked, and then the patient's voice should improve as well. So I would say around 12 months before I'll stick the needle into their neck, because I know I can do something different at that point. If there's no signals, then I will go for a thyroplasty. Or if the patients want a repeat procedure, which I don't think I will go for anyway, if it fails, I'll go for thyroplasty.
Yakubu, thank you for this comment. It's I totally agree from the clinical point. Wilhelm, do you want to give a comment?
Yeah, I'd be more happy if we think about this a little bit more dynamic. That means the interval between the lesion or successful surgery, potentially successful surgery, should depend, the interval between potential successful surgery and the EMG study should depend on the length of the nerve segment that need to be, that need the axons to cross during their growth. So if the muscle is very distant from the suture, it will make sense to do the EMG later. But if the distance between the suture or the surgical procedure performed and the target muscle, if the distance is short, such as 10 centimeters or so, an earlier EMG, in my mind, would definitely make sense. So 12 months corresponds to 12 times 30 to 36 centimeters. That is within the head, certainly is quite some time, and probably some time is lost if we do this with the cranial nerves. The other way around is with peripheral nerves in the arm or in the leg. It may well be too short to wait 12 months for the EMG. So I strongly favor this to take into consideration the length of the nerve segment being crossed.
Thank you for this comment.
Benefit. What's the benefit of doing an early EMG?
I mean, if you have a query failure of your transplant, then maybe an early EMG might be helpful. But if we want to judge the final result, then of course we would also wait 9 to 12 months until we can be sure there won't be any more reinnervation occurring. So, and if that is not good enough, then you have your final result. So, but that doesn't mean we can see the earliest signs of reinnervation usually between 4 to 6 weeks in most cases. But in most cases it's not sensible to do an EMG as early as that.
I think both you are right, and would like to skip the discussion here at this point, because from the clinical point, you have nothing in the back to change the situation, so you can wait on the time point where you have a new option. And from the understanding what's happened in the muscle and from the neurophysiological point, it's clear what Wilhelm said, that you should decide the time depending on the length of the nerve. Now the technical problems are solved, so we can start with the contribution of Kathleen. Before the break, we will show you the workup in our department, and then we make a short break and show you after the contribution of Clark the case presentations.
Yes, we hope we finally solved the technical problems. So what I'd like to show you, it's not.
Thank
you. What are we going to do with a patient that shows up in our clinic? He's got a handout with the voice handicap index, and we like to have them filled out to have an idea of what the symptoms of the patients are. So we've asked a patient to kindly agree to take you through our workup in clinic. So this lady has had bilateral vocal cord paresis, and she has had a laryngeal pacemaker implant. And she kindly agreed to take you through this. So she's filling out the voice handicap index here. So that's what the patient is doing normally before we're going to see them. And then secondly, history taking, very, very important. Always talk to the patient, ask for their symptoms, ask what they're suffering from, and what they expect from you. Then obviously you need to examine them as a flexible or rigid endoscopy, depending on the patient. So you see the lady here having the bilateral vocal cord paresis. There's no audio that I can hear. It's no audio. Okay. So I take you through this here, and unfortunately there's no audio at the moment. So you basically see here her bilateral vocal cord paresis. She has had that implant put in 2013, and unfortunately suffered some electrodes breaking in 2017, and had her done in 2020 a laryngeal glottic widening procedure. So secondly, we look at their breathing and done spirometry. That's what you can see here. We all know this procedure, but just for illustrating how we're doing it in our setting. So you can see the nurse introducing the patient and following her through the examination. The results vary depending on how they're going to do it. And obviously the laryngeal EMG, you see Gerd in the picture, preparing for the EMG. The voice recording that in our clinic normally our phoniatrician Guntinas-Lichius is doing. So you see the patient here. Obviously, you can't hear her. She's got a quite breathy voice. She's counting here and reading the usual German text. And what we do with this patient is as well a 6-minute walking test. She's one of our study patients. That's a reason why we're doing this. Is not we're doing with every patient that comes into our clinic. So it's just an example of what we're doing. you see basically Gerhard at the background, and the patient is walking a specified distance, and you count the rounds that she can make. What you can't hear at the moment that she's got her breathing very heavily. Should I do those normal TAs? And okay, I brought you as well some normal EMGs. This is an example for a normal TA EMG. She obviously can't hear neither, unfortunately. So it's me here. We're doing this in a special setting. Up here is what I show you. This is done with ultrasound too. And you see I've already hit the TA muscle here, going through the cricothyroid membrane and aiming a bit upwards. This is and ask the lady to phonate, and it's a quite strong normal TA EMG. And for the cricothyroid muscle, I brought you an example as well. This is Gerhard doing. So what we do here is you palpate the larynx or use the ultrasound, aiming towards the cricoid, aiming towards cartilage, and you hit the CTA muscle and asking the patient doing a glissando like a E, and here's a normal signal too. And the normal PCA EMG here. It's not using with ultrasound because it's very difficult to show and to get into the ultrasound. So we see the signal of the air going through the CT membrane, bypassing the air, and then doing a drilling. And now I'm in the muscle, having a normal PCA signal, quite a bit of a muscle tone here. Sort of bringing the patient a bit, or calming him a bit, and asking him to breathe, and having a normal EMG signal here. And I'm asking him to phonate now. So it's basically see the line is sort of coming down. And at the end, swallowing whenever. I think we're gonna make a break at this moment of time.
We have time. You can.
Well, I think it's very useless to really show those videos if they don't hear any audio so far. So maybe we can solve this problem by the meanwhile.
So what we can do is that we can answer or answer questions from the audience. Another famous laryngologist joined our conference. Welcome, Markus Hess. Would you like to say your question by yourself?
Sure. Hello, everybody. And I really acknowledge your great work and your tutorials, and also say hello to Wilhelm.
Hi, Markus.
Hi. Yeah, my question would be, because I think a lot of ENT doctors apply botulinum toxin into the larynx, and then we might have different effects that, and my curiosity would be, can you see, or how can you see and diagnose if a larynx or if a muscle was treated with botulinum toxin, especially because when we do that repeatedly, we of course want to intend that the muscle is weakened. And the question would be, how would that be visualization? How can you see that?
Well, I've put an answer in the chat. It is well known for one injection. The time course of the changes after one injection has been studied semi-quantitatively with electromyography. And it is in a way as expected. So it resembles denervation, with the difference that during the first weeks after the injection, due to the blocked neuromuscular transmission, the potentials of the motor units are small, as some muscle fibers are not reached by their nerves. So the signal simply is lower than before the injection. Later, then the denervation occurs indeed. So we found spontaneous activity and even later polyphasic motor unit potentials. We did not study, and I'm not aware of a quantitative study that was undertaken. We did not study the effect of repeat injections. So this is simply my experience in those bigger muscles gained by injection during an EMG needle, that we find slowly but continuously a pattern as is in chronic denervation-renervation processes, such as amyotrophic lateral sclerosis or so. We even find complex repetitive discharges. We find big but not giant motor unit potentials that are polyphasic. So it's a zoo, it's a mixture of findings, with the exception that we do not see those very, very, very big motor unit potentials. So coexistent of some myopathic pattern, as some motor units are small, they are polyphasic, they may be enlarged, and there is spontaneous activity. It's definitely not normal, the EMG after repeat botulinum injections.
Mm-hmm. Thank you.
I can add a question, Markus, if you agree. What I noticed is when we have in ENT some focal dystonias, the spasmodic dysphonia of the larynx, and we see patients after repeated Botox injections over years. Markus, maybe you disagree or agree. They end up with the clinical picture of paralysis. So they result in a hypomobility or an immobility of one side. Do you have an explanation of that?
I don't, but we've also seen that. I never recalled that it was a total immobility, but partial immobility, yes, frequently, I would say. Even after 3 months, I mean, after 4 months, 6 months, but this is just anecdotal because I don't have the data here. But maybe that should be something worthwhile.
Good idea. But Wilhelm, do you have an idea?
Yep, some information from treatment, for instance, of spasticity. With large doses of botulinum. And what we can see there is that over time, the doses required are less, but only gradually over years. And we find some irreversible, let's say, connective tissue degeneration of the muscle tissue treated with botulinum toxin. And we don't think that spasticity is the cause of this degeneration. So I think there's at least theoretic evidence that those denervated muscle fibers, denervated by botulinum toxin, act as if they were denervated by trauma also. Nuclear radioactive degradations. Are already degenerated. At the end of the second year of
Thank you. I think this is an interesting topic for the future. These are really critical ill patients, so therefore they accept if there is hypomobility because the pathologic mobility is their problem. So, but at the end, for us as a laryngologist, the reduced movement of the organ after our treatment is not a good option.
Yeah, that's the difference. When we treat spasticity, we always have the we want to inject more. We want to induce more paralysis. So we are happy with the irreversible degeneration of the muscles as we save doses that can be given to other muscles that require treatment. So it's a wanted, not an unwanted effect in our patients.
For this upside discourse, we have the problem with our case presentation that we have no audio at the moment. So therefore, it makes no sense to demonstrate them without audio. And I think we all are a little bit tired after all these contributions. So therefore, I think that we should take the break right now. And we will start between 4 and 4:15, depends on the line to Clark Rosen. Please be aware 5 minutes after 4 that we can start a little bit earlier with him. Thank you.
Nochmal.
Historical artifact from the American Laryngology Association from one of their first meetings. So it's their 9th meeting in 1887. And if you look at the agenda from that meeting, topic number 4 and topic number 5 were all about the recurrent laryngeal nerve. And here we are in 2021 still talking about the recurrent laryngeal nerve because there's so many things that we don't understand about it, and it plays such an important role. And that's why we're all here, gratefully. And I just kind of capstone that hundreds of years ago to my good friend Norm Hogikian from the University of Michigan. His trilogic thesis was again on the recurrent laryngeal nerve and evidence of central plasticity and things like that. So a little bit more history. This is an instrument from the 19th century. You can see the third one down as an electrical stimulation probe, which some of you may or may not know was attempted to be used to treat vocal fold paralysis. And I put this in for Andreas because I know him and his team have worked so hard on laryngeal pacemaker, and this is the 18th century version of that, you could argue. So let's start off by talking about a patient that we see regularly. I'm just going to show this just for fun, just to get us kind of our appetite whetted, if you don't mind.
Please read. When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Okay, Miss Joan, on this tape recording you're making here, tell me why you're here today.
I'm here to find out what's wrong. My voice is getting weaker.
How long have you sounded like this?
Pardon?
How long have you sounded like this?
Since my operation, February 3rd, 2004, for carotid artery. The doctor doesn't say anything.
I love that clip. As you can tell, it's very, very old. I date myself by playing that clip, but I love her because a couple things. One is that the doctor doesn't say anything. She's absolutely classic breathy. And so here's what patients ask us when they come see us. Is my voice going to get better? And then we usually say, well, to a certain degree, it depends on if your vocal fold regains motion. I have some literature, I have a quick article to share with you regarding that. And so then the very sharp patient usually says, well, can you tell me if my vocal fold is going to move again? And then the doctor says, can EMG help us? And that's why we're all here. So that kind of sets the tone. This is the article I was referring to. This is a very simple article that we published a while ago looking at voice outcome as it relates to acute vocal fold paralysis. And we followed everybody prospectively after they had an acute vocal fold paralysis, and we monitored their VHI-10 as a metric for normalcy of voice prior to permanent treatment. And what we found is that if you got return of, if vocal fold motion recovered, you had an 85% chance of having a normal VHI-10. If you had no motion of recovery, you only had a 20% chance of having a normal VHI-10. And so motion is really key. It's not the only thing, but it's really key. And this is where I kind of now develop what I teach my residents, the 80-20-20-80 rule of vocal fold paralysis. So if you have motion recover, you have an 80% chance of having a normal voice. Without any further treatment. If you have no motion of recovery, you only have a 20% chance of having a good voice. So sometimes I find that helpful when I'm counseling patients. So let's talk a little bit about neuroanatomy. We think about wiring and engineering of the larynx, and the old school ear, nose, and throat approach about laryngeal innervation was there's 4 nerves going in, a right and left superior laryngeal nerve and a right and left laryngeal nerve, and that's all we got. But it's actually much more complicated than that. And that's why we struggle, and that's why we've been talking about this for hundreds of years. So I just wanted to very quickly talk about intralaryngeal neuroanatomy because I think it's so important. And I am frustrated that we're not talking about this on more of our conferences. And so I'm just going to blow through what I find really, really important for us to be thinking about as we delve deeper and deeper into laryngeal neuroanatomy, and as we think about laryngeal recovery following vocal fold paralysis. So Galen's anastomosis, we all learned about in medical school, and that's a connection from the internal branch of the superior laryngeal nerve to the recurrent laryngeal nerve. The interarytenoid connection going from side to side is another important. The human communicating nerve, Ira Sanders popularized about 20 plus years ago from the external superior laryngeal nerve to the recurrent laryngeal nerve. And so these interconnections are, I think, are extremely important. The studies have shown that they're motor as well as sensory. The superior laryngeal nerve, I think, probably plays a much, much bigger role in laryngeal injury and recovery from laryngeal injury. I think that these interconnections play a big role in the position of acute vocal fold paralysis. And I think they also play a major role in synkinesis, as we're going to talk about soon. The work out of the Spanish group, this Spanish group has been outstanding. I think they're under-recognized and underappreciated. And if you have time, I encourage you to read their work because it's really, in my opinion, a game changer and should be lauded. So let's start with a definition of vocal fold paralysis. I wrote a paper with a bunch of colleagues and published it in the European Archives of Neurolaryngology in 2015 to give a distinct definition of vocal fold paralysis. And so that was a completely immobile vocal fold due to a known or strongly suspected neurogenic etiology. Usually it's a recurrent, could be vagus, could be a central, but it's pretty rare. So this is no purposeful motion on either adduction or abduction. One of the things that I think is important for residents and fellows to remember is that when we say vocal fold paralysis, it doesn't mean that there's electrical silence. In fact, we have a publication showing that only 9% of long-term vocal fold paralysis are electrically silent. 91% have a substantive amount of reinnervation. When you took an EMG needle in a year later, there is a significant amount of electrical activity in a permanently paralyzed vocal fold. And so that's kind of the conundrum. We know there's electrical activity going on, but we also know that that vocal fold's not moving. And our job is to figure out why and to know some more things. So I wanted to change gears and kind of do a little bit of a session about talking about what I know, how I practice, and my biases, if you will. So this is kind of my acknowledgement of kind of my concepts of laryngeal EMG. We definitely have limitations of laryngeal EMG, and I want to talk about the values and indications of LEMG as well. So I'm just going to walk you through this. LEMG is definitely both art and science. The art is the qualitative interpretation. There's nothing wrong with qualitative interpretation. If you think about we rely on and we make life impacting decisions on chest x-rays. And there is nothing more qualitative than a chest x-ray. The heart's a little bit big, there's a little fluffiness at the periphery. We make all these decisions, interpretations on a chest x-ray, and nobody ever says, can you prove it? Because it's just grown to become how we practice medicine. But there's also a science component, and we're going to talk a little bit more about that. In my opinion, best results from laryngeal electromyography come from two expertise coming together. One is in electrophysiology. Typically, that's a neurologist. There is another specialty in America called physical medicine and rehabilitation. I don't know if there's an equivalent in Europe, but you need somebody, I personally think, that you do your best work when you have somebody who's spending day in, day out, sticking needles in people's bodies and measuring the electrical activity at the tip of that needle. And so I think that that's important. And equally important, you have to have somebody who understands laryngeal anatomy, because they've got to place the needle in the right place, and laryngeal disease. And so I don't think a neurologist or electrophysiologist can do what we do as a team as well, and vice versa. A laryngologist who's not an electrophysiologist expert, I don't think does as well doing an EMG as a team. So I think that dual expertise is important. We have some limitations for sure. Right now, to my best of my knowledge, we can't do nerve conduction testing on a regular routine clinical basis. There's been some interesting experiments over the years. I'm not going to go down that rabbit hole, but we definitely have that limitation. You can have problems with patients not cooperating. Not everybody loves the idea of a needle stuck in their neck, and so that can throw off your results of laryngeal electromyography. You can be in the wrong place. I've been in the wrong place. I've had my needle in the wrong place many times. And I've had to admit, like, I don't think I'm in the right place. I don't think I can get there. It doesn't happen very often, but we have to acknowledge that that is a limitation to laryngeal electromyography. And then lastly, we don't fully understand the intralaryngeal neural connections. Who has a very strong Galen's anastomosis, and what that means to their vocal fold paralysis prognosis for somebody who has very little intralaryngeal connections, and what it means from their prognosis. We've all seen patients have the exact same type of injury to the recurrent laryngeal nerve with very disparate outcomes. And I think it's this intralaryngeal neural connections that plays such an important role. The other important caveat that I want to tell you about is that one of the things I think is an important clinical care practice principle is that I don't ever order a test or perform a test unless it's going to change what I do clinically. If I'm doing research, that's different, but when it's coming to patients, it's that. So I don't do laryngeal EMG just because I can. I only want to do laryngeal EMG if it's going to change how I treat the patient. And so I think that's an important guiding principle. And related to that, I don't do laryngeal EMG in patients with suspected vocal fold paresis. I do believe in the concept of paresis. I think paresis is very poorly defined, very controlled, understood, and I think it's widely diagnosed differently at different centers around the world. And some people look at tone, some people look at false focal fold, some people look at motion. And so I don't think that from a clinical care perspective, laryngeal EMG has much role in paresis. That could be fighting words for some people, but that's just my perspective. Again, I've never seen a laryngeal EMG change how I'm going to take care of a patient. Late vocal fold paralysis, 6, 8, 12 months after the onset of paralysis, I don't think laryngeal EMG has much of a role most of the time because it's not going to change what I do. I can't think of a situation at somebody who's 12 months out where I stick a needle in their larynx, interpret the electrophysiologic findings, and then determine, do something different than I wasn't going to do before I stuck a needle in their larynx. So again, some people may disagree with me, and I hope that that's the case so we could talk about it, but that's my approach and my thoughts. Another area that's super interesting, and I'd love to talk about this if we have time, and that's early vocal fold paralysis. So somebody wakes up from spine surgery, somebody wakes up from thyroid surgery, they're hoarse, they're in your office, they're 1 to 2 weeks out. Is there any value to EMG right then? Are you going to do something different with that EMG result finding? Probably not, unless you're going to think about using nimodipine. And I have not written nimodipine slides in here. If everybody wants to talk about nimodipine, I'm more than thrilled to talk about nimodipine. And if anyone's read our work on nimodipine, I would tell you, I'll tell you the #1 criticism of our work in nimodipine is that it has relied on early EMG, which has never truly been validated. And we just kind of blindly accepted it as a valuable, but I don't think we know that for sure. So here's what we're talking about. Everyone's seen this, done this. I heard you guys had a talk earlier about it. I describe this to patients as the EKG of laryngeal muscle innervation. It's relative, in most patients, it's simple, straightforward to perform. There's 2 categories of things we learn from laryngeal electromyography. There's qualitative measures, which I'm not going to discuss really at all today. And Andreas told me that you guys already talked about this. And there's quantitative measures, and I'm going to spend most of my time and energy talking about quantitative measures. So here's the typical EMG tracing. This is a little bit of a fuzzy signal, but the sound is perfect, and that's really what's important to a certain degree. One thing I'm going to give you a hint, give you something to look at. It's interesting. This is a foreshadowing I just realized. When I play this video again, if you look up here in this little box up here, you'll see these color bars. It goes from green to yellow to orange to red. And that's actually quantitative EMG. And what that is measuring is called number of short segments, which is a objective measure of how close your needle tip of your EMG needle is to the electrical generating aspect of the neuromuscular unit. I'm going to show this to you one more time. So this tells you basically how well is your good, how well positioned is your needle to where you really want it. Then I'm going to show you somebody with a classic decreased recruitment. It's that classic repeating one little, we always talk about Mike Munin. Mike Munin always uses the analogy when he's talking to patients about, like, that there's, that you've got a boat, a rowboat, and there's 10 people who've got to row the boat to move the boat forward. And in this person, they've got only one of those rowers are actually working, and he's just working again and again as hard as he possibly can, but that boat won't move until you get enough rowers in the boat all moving in the right direction. So I want to talk a little bit about laryngeal synkinesis. Let's just first back up before we talk about laryngeal synkinesis. Let's look at some history of laryngeal EMG. If you look at the old literature, laryngeal EMG has not been very good at prognosticating vocal fold paralysis recovery or lack thereof recovery, because there's great value to telling a patient, I'm going to stick a needle in your larynx and I'm going to tell you it's not going to come back and we can move on. And as well as, obviously, I'm going to stick a needle in your larynx and I'm going to say, hey, let's just wait for a couple more months because you're going to get better. There's great value to that clinically on both sides of the coin, I would submit to you. So these are the historical numbers. And here's what used to happen. Here's what happens. A typical clinical scenario. Patient has thyroid surgery, they wake up hoarse, you examine the larynx, they have an immobile vocal fold. And you say, let's do a laryngeal EMG. You stick a laryngeal EMG needle, you stick an EMG needle into the larynx, you get robust recruitment, a big interference pattern, and everyone's happy. The thyroid surgeon feels better, you feel better, and you tell the patient, hey, you're going to get motion back, just wait. It's going to be okay. And then the patients wait and they come back to see you, you look in their larynx, no motion. And then you have to say, hey, we were wrong. And the question is, what are we missing? Why do we have such a bad result in that scenario? And I would submit to you, one of the major reasons we have a bad where that scenario occurs is because of laryngeal synkinesis. The concept of laryngeal synkinesis has been around a while. Dr. Crumley has been talking about this for years. I cited his 2000 paper because it's really important, but when I was looking last night, he published about this in like 1986, Blitzer as well, and really, really important, thoughtful work on laryngeal synkinesis. So the concept is that the TA-LCA muscle has been reinnervated by some other source other than the original innervation from the recurrent laryngeal nerve. Is it maybe only partially reinnervated? Is it incompletely reinnervated? Is it reinnervated from an abductory source, so it's not firing at the right time? Has things changed in the CNS, what we call central plasticity, which nobody ever talks about? And this is the reason I started with talking about intralaryngeal neural anatomy, because all those little interconnections are right in that area. And so after an acute vocal fold paralysis occurs, we know that there is basically messaging that occurs from the denervated muscle that is the equivalent of shouting out, saying, I've lost my neural source, I need nerves to come innervate my denervated muscle. And so nerve growth factor is amplified and nerves from the surrounding area sprout to innervate that muscle. but they may not be the right nerve source. They may not be wired centrally appropriately to move the vocal fold at the same time as all the other laryngeal muscles are working together. And that's the concept of laryngeal synkinesis. So we set out to try to verify this and look at this by doing a very simple test. We said, let's put the laryngeal EMG needle into the thyroarytenoid, lateral cricoarytenoid muscle, into the muscle of the vocal fold. And let's measure it during sustained phonation when it should be really active. And let's measure it during a sniff maneuver, just when it should be relatively quiet, not absent, okay? And then we also put an acoustic microphone on the neck so we knew exactly the start of the E and the start of the sniff. And so this hopefully is, this is the EMG tracing up here on the first channel. And you can see during the sustained phonation, during E, you've got this big, robust, large amplitude firing again and again and again, super healthy, super good. And then it tails off as soon as the phonation stops. And here's the patient sniffing. There is a little bit of EMG fire, which makes sense. And EMG studies have shown before. Al Hallel's trilogic thesis showed that the TALCA fires during a sniff, and it kind of, in theory, stabilizes from the activity of the posterior cricoarytenoid muscle. So what we did was, we just come up with a simple idea. Let's measure the maximum amplitude during phonation, and then compare it and divide it versus the maximum amplitude during sniff. So that's where we got this sniff to phonation ratio. And then we started doing this in all of our vocal fold paralysis patients. And so here's somebody that has what we call a positive synkinesis testing. So here's their acoustic signal for E, here's their sniff, and then you can see they fire during sustained phonation. So they've got a pretty robust recruitment pattern during sustained phonation. And then they take a break, and then they sniff, and lo and behold, another robust fire pattern. We'd have them take a break, have them sniff again. And so this person's ratio is 0.72. And so this is a person that had what we would call as positive synkinesis testing. And we never knew that this existed. And I'll share with you how we implemented this data and how it gave us some insight into prognosis. So in a fairly good sized cohort of patients using our EMG prognosis guidelines, which are published in multiple different sources, you can see that our negative predictive value, our positive predictive value, our sensitivity and specificity were not very good. And that's representative of the literature from the 1970s and the 1980s. But then when we added in synkinesis testing, and what we did, this is super simple and crude, what we did is that if we put people into three categories for prognosis. You have a good prognosis for recovery, you have a fair prognosis for recovery, you have a poor prognosis for recovery. And so if you had positive synkinesis, but everything else was put you into that fair category, we dropped you to poor. So we dropped everybody one level of prognosis if they had positive synkinesis. And when we did that on the exact same group of patients, suddenly we were able to significantly improve our negative predictive value, our positive predictive value, our sensitivity and specificity. So I think to a large part, this is our missing, this was the missing link. And this explains why we haven't been very good at predicting recovery or not. So let me transition to quantitative laryngeal electromyography, which is a pretty simple thing to explain. Basically, quantitative laryngeal electromyography is taking this EMG tracing and measuring every time the tracing moves in a positive to negative and in a negative to positive way. So every time the tracing flips, it counts that as a turn. And that's the measure of turns per second. And then since it's measured this point objectively by computer analysis and by this point, then you can also measure amplitude. And so we get two things that are really helpful. There's a lot more data that's captured during quantitative turns analysis. And I gave you an example of those color bars, and that's what's called the NSS. And we now are using NSS to guide Botox needle placement, and have shown that using NSS, i.e. quantitative laryngeal electromyography, improves accuracy of Botox placement. And so I guess I won't, but I do quantitative EMG on every Botox injection I do, even though I've been doing Botox injection for longer than I wish to admit, because I think it plays a real important role. So on this screen here, this is your classic EMG tracing, and all these little dots, this is number of turns, and then this is amplitude. And so at many different times during this tracing, we captured a short segment, and the computer analyzed the number of turns and the amplitude during that short segment, and then mapped it out on this XY axis here. So this is turns, and then this is amplitude. This red box is called a cloud, and this is a normal distribution of soft phonation, loud phonation, more turns, less turns, type of thing for doing quantitative laryngeal electromyography. And here's an example of a video of quantitative laryngeal electromyography. You're going to see these little dots populate on the XY axis during the video, and that's us capturing or performing quantitative laryngeal electromyography. A whole bunch of different little sampling places, and you can even move the EMG and sample from several different fields within the TA LCA muscle complex. So that's basically what quantitative laryngeal electromyography looks like. Here's kind of a better example of neuropathy. You can see the classic qualitative, one little muscle motor unit firing again and again and again, exact same unit. And you can see how the turns have been shifted way, way left. And so just to put this in practical terms, the first paper we did when we were looking at who's going to recover from vocal paralysis and who isn't, we found out that a turns of greater than 400, which is probably right about here, means that they have a really good likelihood of recovering versus not. And so when they're shifted way left here, and there is an slight increased amplitude, because often when you see this neuropathy, you'll have increased amplitude because you've got one little neuromuscular bundle attached to a whole bunch of more neuromuscular units, and so the amplitude increases. So here is a typical vocal fold paralysis. Here's what we call the cloud, and the blue boxes are the vocal fold paralysis side, and the green triangles are the contralateral normal vocal fold. So you can see everyone's been shifted to the left, and nothing is above 400. And then here's kind of a classic neuropathy. Everything's shifted to the left, and there's this big amplitude here, which is typical for chronic neuropathy or denervation, reinnervation, where the amplitude is increased as well. And so this is the most recent publication that we did when we were putting all these together: synkinesis, qualitative laryngeal electromyography, and quantitative laryngeal electromyography. And our negative predictive value, positive predictive value, all were pretty darn good, significantly improved from historical controls for sure. Not perfect, there's still limitations. And so this is why, our group felt that the combination of the quantitative, synkinesis, and qualitative all really can help pretty significantly and be quite reliable. One thing I wanted to, let me just get rid of this because I'm afraid it may be hide meeting controls. There we go. Sorry if that was blocking out. One thing that I think is the kind of a future area of investigation is what I call laryngeal neuroplasticity. And not enough people are talking about this. They talk about it in facial nerve a lot. They talk about it after CNS injury and brain injury, but we don't ever talk about it in the larynx. So, and I think this is a really important to surgeons who are performing laryngeal reinnervation, because everyone right now, at least in America, it's a very hot topic to do laryngeal reinnervation on a vocal fold paralysis patient. And I personally don't think it's a value, because it's not going to make the vocal fold move again. But, you know, after there's been an injury, there we go. There we go. We've lost that connection, and then the connection gets collected, but we don't know if it's going to the right location in the brain anymore. And then we know that the brain, after there's been a short period of denervation, that CNS location, motor location changes. And I think that's our biggest problem right now. So I just wanted to throw that out there for you as something to think about. So last topic is determining prognosis. Here's my thoughts. We've done a paper, published a paper on that. Greater than 400 turns is an important prognostic finding. Positive synkinesis is a poor prognostic finding. I'm prone to doing serial laryngeal electromyography when I see somebody relatively early. We all know some patients show up at 9 months after the injury, some show up at 9 hours after the injury. And so those patients are very, very different to manage in my practice. So if I can get 2 points on a line, I can do an early EMG at a month, and then I do another EMG at 3 months, and I can see where they're going. If they're getting significant new recruitment and an interference pattern is growing, I'm going to be relatively optimistic. But if they're not changing at all, then I think the chances of them getting purposeful motion is really poor. So I am interested in serial EMG. I've not published my results on serial EMG, but it is, I think, something of importance. So the clinical value of EMG, I think it's helpful to the timing of medialization. How long do we wait? We published a paper prospectively looking at the impact of laryngeal electromyography on clinical care. And so if you're interested, you could read that article. It's not uncommon that I'll see patients that have an acute vocal fold paralysis from surgery, and then that patient needs the other side done. The other carotid done, the other thyroid done, a neck dissection for thyroid malignancy, whatever it is. And then, you know, the surgeon wants to know, the patient wants to know, what's the likelihood of me, you know, if you know, am I going to end up with a bilateral paralysis? And so the surgeons want to know, hey, if I wait 2 or 3 more months, will this vocal fold that's the first paralysis recover, and then it'll be safer for me to do the contralateral side. So laryngeal EMG, I think, is vital for that. If there's a question about paralysis versus precoital node dislocation, EMG is really, really helpful for that. And so kind of in summary, paralysis versus dislocation, a prognosis for spontaneous recovery. I talked about good, fair, and poor. And then I think it also can guide treatment regarding the need for temporary treatment, the need for permanent, for spontaneous, looking for waiting or proceeding with permanent treatment. So those are some of my thoughts and ideas on laryngeal electromyography. So I hope we have questions, and we definitely seem like we have time for it for sure. Before I stop screen sharing, I'm just going to invite all of you to come to San Francisco next year. The Fall Voice Conference is going to be in San Francisco next year. It will be in person. There will also probably be a hybrid aspect of it as well. So I hope that you'll consider coming to San Francisco next year. I'll stop talking.
Brilliant. That was an excellent presentation, Clark. Really enjoyed that. So we've got a few questions here. The first one is, let's see now, I'm going to scroll down. So to your Statham paper, is there a physiological co-activation of the PCA during phonation?
So if you go back, yeah, the answer is yes. And it was Al. If you go to Al Hilal's trilogic thesis, it's absolutely brilliant. I've read it more times than I want to acknowledge. But what Al Hilal did is he did fine wire EMG, and fine wire EMG is a technically difficult technique to perform, but what's cool about it is that you place these little small fine wires and they hook into the muscle. And then you take the whole needle out and then just this little wire sitting there. And you can do this on multiple muscles in the head and neck area simultaneously. And that's what Al Hilal did. And so Al Hilal did the first that at least I know of, simultaneous EMG recording of the TALCA, the cricothyroid muscle, strap muscle, and the PCA muscle. And so if you go back to his work, we do know that there is firing of the TALCA during a sniff activity. And that's what we predicated the synkinesis testing on.
There's another question here. How early do you expect synkinesis to occur?
Yeah, that's a great question. That's a great question. You know, and Mike Munin and I have been surprised at how early we've seen synkinesis. I'm not sure if I can give you a number, but I think we've seen synkinesis as early as 2 to 3 months, which is kind of amazing. And, you know, as I said, my EMG partner, Mike Munin, you know, he does EMG. The innervation pattern and the recovery of the larynx is not like any place else in the body. I don't see this type of activity in other EMGs I do. So I don't think anybody knows how quickly synkinesis can occur. It would be really cool for us to do an animal model of that, but I don't think we truly know yet.
I think we still have time, so perhaps I can ask you a few questions as well, if it's all right. So I presume that you use local anesthetic infiltration before you do the test, and if you do you find sometimes it may cause some interference with the signal? So
I used to, I don't anymore, but I used to just inject a small amount of lidocaine subcutaneously. But I now have, you've been using for the last, I don't know, 6 years or so, what's called a skin refrigerant. We call it freezy spray, but it basically, you spray it on the skin, and the skin gets very, very cold, and as a result, it becomes anesthetic for about 30 seconds. And I think that I know you, Kubo, you're a footballer, but you know, every time Paul Pogba, you know, gets fouled, he rolls over in agony, and then the trainers come out and they spray this stuff on him, and then he gets up and then scores a goal. I think it's the same type of stuff. I don't know.
It must be. It must be. That's very clever thing, actually. There, very clever thing to do. Yeah. I do it for all my Botox patients, and I love it because it doesn't distort any of the anatomy. And so I always struggled with, you know, injecting a little bit of local, you know, changes the feel and the anatomy of me passing the needle through. So I would see if you can find this. If I remember right, the name of the commercial name of the product in America, I think, is called Pain Ease. I'm not sure, but the category is called a skin refrigerant. I mean, with the faculty, I don't know if anyone has experienced the local anesthetic causes interference. Has anyone had that experience, especially when you inject it deep?
I've definitely never injected deep.
What about electrical interference from the room that you are doing? Do you often find sometimes it can be an issue?
Super important. And about 15 years ago or so, I had the luxury of building a new clinic. And when I was designing the clinic, I met with the engineers, you know, the electricians, and I said, this is the room I'm doing an EMG in. and I want to use this electrical outlet for my machine, and I don't want any other wiring going to that electrical outlet. So I had them build me an isolated electrical source. So, you know, often from a little bit I know about electrical wiring is that the outlets in the room can all be interconnected. And if that produces some white noise or some electrical interference. So from what I've been told, that's the way to go about it. Probably newer machines have a way to isolate that. But a million years ago, I used to try to do EMG in the operating room, and it was impossible. There was so much electrical activity in the OR. I struggled. I think people do it, but I do think it's an important thing to think about. And the way I solved it was telling my electricians that I needed a dedicated electrical outlet that wasn't connected to anything else.
And with the technique for the PCA, do you prefer going from the side of the neck, or do you prefer going through the cracopharoid notch?
Right. Good question. I typically do not do laryngeal electromyography on the PCA, just because it's hard for me to have the EMG needle in there long enough for me to really get a good signal to do something different. And I just haven't played with it, to tell you the truth. When I do Botox PCA, I rotate the larynx if at all possible. So I'll usually, put my hand around the larynx, rotate, and then try to go around the back to do a Botox injection. But I don't routinely, PCA is not part of my routine diagnostic EMG protocol, at least right now. I'd be interested to see if other people do that and how they do it, and more importantly, how it changes what we do, how it changes about our knowledge, and maybe how it changes our ability to prognosticate, because it's something I'm interested in, but I haven't done.
I think from the Jena team, I noticed they go through the cracopharoid notch technique. So I presume they will anesthetize the vocal cords, and I think they put like codeine to reduce the coughing. This was what we saw today. Any more questions come in? Otherwise, I've got one more question. As you know, as these patients wait for their final or definitive procedure, sometimes they have injection. And do you find that if you have an injected substances in the paraglottic space, if it affects?
So yeah, it's a good question, Yakubu. We just published a paper a couple of years ago. Libby Smith, I think, was the senior author on that paper, where we looked at a consecutive series of patients who were augmented, and we had the electromyographer blinded to determine if the presence of material altered his ability to interpret the EMG findings, and the answer was no. So I think that you can still do good EMG in the presence of a temporary augmentation material. You will find locations within the paraglottic space where there's not much, there's a funny EMG signal. And so I think that's when you find a pocket of the temporary material, but then you can move past it and get a good EMG signal. So it's helpful to know if there's temporary augmentation material on board, but I don't think it alters our ability to prognosticate. That's an important question.
I think Andreas Müller has got his hands up.
Yes, Yakubu. Clark, the change between your experience and the European experience is that you can draw a positive predictive prognosis for recovery of movement. Our published papers still only can predict negative prognosis. So maybe the game changer is the quantitative evaluation of the EMG. So my question goes to how reliable is that? Because we learned from Wilhelm this afternoon that the result could be changed from different voluntary activation, and it could change to the different position inside the muscle. We have different situations like resting innervation, synkinetic innervation, denervation. So have you ever examined 3 or more points inside the TA-RCA complex and compare them?
I try to measure at least 2 or 3 fields every time I do it. And so, you know, there is a lot, the art of laryngeal EMG is getting a patient comfortable, getting them to relax and kind of, you know, turn off all the other activities for sure. And then measuring a couple different fields. And my electromyographer, both here in San Francisco, as well as Mike Munin, would always say, hey, can we move the needle a couple millimeters and then let's redo it. So usually I'm sampling at least 2 or 3 different areas. And I think that you can definitely get an artifact. You can definitely be out of the larynx and get get bad findings. And so to corroborate, you know, my electromographers feel more comfortable when I put the needle in and I say, okay, I think I'm there. And then we do a whole series of recordings. And then we move the needle a couple of millimeters different, and then we do another series of recordings and they show the exact same thing. And then we'll move the needle one more time and we get the exact same recordings, then we are pretty confident. But if I get the needle, I put the needle in place number 1 and it shows poor recruitment, electrical silence, just a couple fibs, and then I move till 2 millimeters and I get this robust recruitment, then you're like, what is going on? And so those patients are definitely harder to figure out what's the real finding there. And so I think that your electromyographer is right that, you know, there's still an art to the needle placement. There's still an art to the interpretation. And so you have to take everything into consideration. And so it's not always black and white. It's not always easy. The best ones are when you get the exact same findings in 3 different locations, then I'm really, really confident.
So Clark, how have you used this cutoff value of 400 turns per second? Is that as soon as you reached the 400 with some points, or half of the points have to be above 400, or all have to be above 400? What is your cutoff of 400 mean?
Yeah, it's a good question. It's usually pretty obvious, to tell you the truth. You know, we don't get that, we're getting, we're probably sampling 5, 6, 7, 8 times or 8 places or so, you know, different tasks, different locations. Almost everything is, you know, when I say that somebody's got a poor prognosis from quantitative EMG, you know, everything is shifted to the left and almost everything is below 400. It's unusual in a neuropathy situation to get a spread of findings. They're usually pretty clumped.
Right. Any more comments or questions from the delegates, especially?
Well, Wilhelm, do you have a comment?
Yeah, probably. Hi.
Hi.
At first, the most important comment that I like your talk very much. As I'm a neurologist, I'm not only keen on learning from other disciplines, but especially from you. And so I have one comment, but on needle position. It is a common law for neurologist electromographers to study different areas in the muscle, not to rely on the finding of one area. And then you mentioned that if you position the needle in one place and you get some fibs, and in another position you get a normal EMG, you don't know to rely on which finding. In my mind, if there's clear-cut pathologic spontaneous activity, such as fibrillation potentials, and if this is sure, this needle position should be regarded as an important one. As in healthy tissue, there's never spontaneous pathologic spontaneous activity. So in my patients, I would rely on the finding of that area. And if there's only spontaneous activity, but no motor unit potentials,
right,
I'd conclude to a complete functional loss of function of that nerve.
right. So here's our, yeah, totally agree. Here's our problem in laryngeal electromyography, is that we never know exactly where our needle tip is. No matter how good Yakubu and I think we are, we have to admit that I don't know exactly where the needle is.
Yes.
And, when you do a EMG on someone's bicep, you hold their hand, you hold their bicep between your fingers, and then with the other hand, you stick the needle in the bicep, and you know exactly where it is in the bicep. We don't have that luxury. And that's when we get these, that's when the hardest EMGs to really know what we're doing is when we get these two binary disparate findings. One, I'm in location 1 and I'm being fibs, and I move 2 millimeters, deeper, 2 millimeters lateral, 2 millimeters cephalad, and I'm getting a full recruitment pattern. And then my electromyographer and I look at each other and go, I don't know. And then he has to look at me and say, which needle place did you think was real? It's not, you in a scar, and don't forget, these people have almost all had surgery in their neck, also radiation, or so their neck anatomy is not great. And so I can be outside the larynx and be in the cricothyroid muscle and get this great fire, and not really know I'm in cricothyroid muscle. So, or I could be in strap muscle. We have standard tests to determine if we're in strap muscle or not by having the patient lift their head up off the table. And so I think it requires that teamwork and that honesty about, do I truly know where the needle is? And my electromyographer will say, well, tell me which needle placement you think you're most confident about. And then I'll try to we try to use that results. But you're completely right, Professor. It's a challenge when you get those two responses. I completely agree.
Totally agree with you, Rosen, the position, the precision, and the only other alternative to that, which Jean-Paul Marie does a lot for his selective reinnervation, is to do that on the in the operating room, in the local anesthetic and some degree of sedation. Then you pass the laryngoscopy there, and at least you can see the PCA with more certainty, and then the LAS, LCA as well, and the TA. Yeah. So that way you can be more certain to say, okay, I'm probably 95% in the muscle or even more.
Yeah. Yeah, I mean, when we do Botox injections, it's so easy because we listen and look for that, great interference pattern. And so, I almost feel like on certain days I could do Botox injections blind because I put the needle in, I get this robust pattern, and I'm there. But then in my old life in Pittsburgh, I used to do Botox injections all day, and then at the end of the day, I would do laryngeal electromyography. And so it always struck me how much harder EMG was, laryngeal electromyography was, because I didn't have that gold standard of finding the firing pattern. I couldn't rely on the EMG signal to know I was in the right location, because if the person's denervated, I'm not going to get that pattern. So it becomes much harder technically to know I'm definitely in the right location or not.
Marcus, I can see your hands up, and I saw Andreas Muller's hands up earlier as well, so maybe he's changed his mind. But Marcus and Andreas, comments?
First, I want to say hello to you, Yakubu, and Clark as well. Hi there. And
hi, Marcus.
I really enjoyed your talk. I mean, you're brilliant in education and tutorial. I have actually two comments. One comment, one question for you, Clark. So the comment would be, I think our learning curve can go up when we first do a very extensive flexible endoscopy visualization of the arytenoids with many maneuvers, and then having in mind how the three-dimensional complex movement works. Then when we compare that with the EMG, that I think is a learning curve. And I must say, I think you should use the flexible endoscope and not the rigid one. And then my question for you, Clark, I know you like to have an approach of making things simple for young learners. Now, my question for you would be, when you did so extensive EMGs from percutaneous, what was your biggest problem and maybe the mistake you made for a long time until you found out that you found an easier way to do that? Just to simplify or to explain what I mean, for me, it was an eye-opener to very steeply go up into the larynx from the outside. So in the first, I don't know where I was, and in the very beginning, I actually didn't get many signals, but when I learned that from others, then I had a better outcome. But what was your trick, or let's say your experience?
Perfect. Marcus, great question. And I'll tell you, I do have a trick. You know, the textbooks, if you read Andy Blitzer's textbook, he talks about entering the cricothyroid membrane about mid cricothyroid membrane. And I think he talks about 45 degrees off and 45 degrees up. And I have found that's not a good technique for me, at least in my hands. So I like to enter the the larynx and get access to the TA-LCA muscle complex, about 5 millimeters off the midline at the superior aspect of the cricothyroid membrane. So I'm feeling the inferior border of the thyroid cartilage if at all possible, and I want to enter right there. And as soon as I pop through the cricothyroid membrane, I drop my hand and I go almost straight up, just like you said, Marcus. And I would say what surprised me the most is how often when in the beginning, I would not feel the cricothyroid membrane and I would pass through the first 4 or 5 millimeters of the TALC muscle and I would be too deep into the vocal fold.
Okay.
So I go very slowly because I often get really good EMG signal immediately after I get through the cricothyroid membrane. It's like that. You know, it's like no fire, you know, no signal. I'm through the cricothyroid membrane and then boom, I'm right there and I'll stop. So I stop more, I'm more superficial than I ever used to be, you know, 20 years ago. And that's been my learning point. Was I think in the beginning, I thought the muscle was deeper than it actually is. And so I will stop right through when I get through the cricothyroid membrane, sample there, measure, and then either advance a little bit more deeper, advance a little bit more lateral, go a little bit more cephalad. But that's been my kind of my aha moment, so to speak.
Okay. I think this is a very great point. And one quick question for you, Clark. Do you think that in all cases it is possible to go to the TA muscle or TA-LCA complex from the outside, percutaneous, let's say 5 millimeters offside, which I also like, but can you always avoid going intraluminal? Or
sometimes I get in the airway. When I get in the airway, when I'm looking, when my electromyographer keeps asking me to look for other areas. You know, when we don't have a clear understanding of what's going on, he was like, let's check another field. Let's check another field. And that's usually when I get into the airway. So
maybe
I
can extend that question also to the others who do that more regularly, like the Jena, Gera group and Yakubu. How about you?
Yeah. What of tips even for myself that, well, for me, it's the patients that the Botox hasn't actually quite wear off, and then you're trying to find signals, because there are patients that come, say, 2 months down the line, they feel like they want another injection, and then put the needle. I spend so much time trying to find signals, and I say, well, I knew anatomically I would be in the right place, but not much signals. So now I still inject, and then they come back to say, oh yeah, it does work.
They all do.
Yeah. I think Andreas, you put your hands up for a while now.
Yeah, I would only comment to that. I think in normal anatomy, we all will reach the TA, but we have sometimes critical patients, and my advice is what we should look in future is to use the ultrasound. You can use the ultrasound before and mark some landmarks that you really know where the inferior border of the thyroid cartilage is and the midline and so on. And maybe Kathleen in her presentation afterwards will show another possibility. You can also use the ultrasound as a guidance for EMG needles, for Botox needles and also for EMG needles. The system is still not really fit for daily practice. This is still more a scientific approach, but maybe there's a future to use a navigated ultrasound to control where the tip of the needle is placed. And then you really can compare the result of this needle position to the muscle you want to reach.
Yeah, that's a great idea. That's a great idea. I mean, we've all sit there and sweated over patients' necks who are woody, scarred, multiple surgical incisions. It's painful, and I can barely find where the larynx is, no less where the inferior border of the thyroid cartilage is. So the ultrasound sounds like a great idea.
So thank you all. I'm really sorry to end up at this point because we want to give Kathleen the chance to present her case presentation. Thank you, Yakubu, for your perfect moderation. Thank you, Clark, for your really impressive contribution, and good luck for your next date today. And thank you for having you here in our workshop. And we now want to change to Kathleen's presentation.
Perfect. Thank you.
Yes, hello everybody again. And thank you very much, Clark Rosen, for this wonderful presentation. It's very interesting. So we're coming back to our case presentations, and we hopefully solved our technical problems. So the first case I wanted to present you has been about a lady we've been seeing a few years back. She's a nurse in our hospital. At that point, she was 38 years old. Female. She had done thyroid surgery in November 2017 and suffered a postoperative recurrent nerve paresis on her left side. She first presented to our clinic in December 2017 and complained about dysphonia, shortness of breath on exertion, and some swallowing problems, means just a slight aspiration on fluids. So this has been her larynx when we first saw her. I'm very glad we're having her possible to hear now. So on the left side, you see the vocal cord being in a pyramidal position, the aries slightly inverted, a bit shortened, and a clear posterior gap. Voice at that moment.
Der Nordwind und die Sonne. Einst stritten sich Nordwind und Sonne, wer von ihnen beiden wohl der Stärkere wäre, als ein Wanderer, der in einem warmen Mantel gehüllt war, des Weges.
Her EMG that we performed showed a normal activity on her right side, obviously to be expected. And on the left side, she had some widely reduced recruitment pattern, and on the CTA muscle, single fiber pattern, and some spontaneous activity. No synchronesis side, going to show you this here. As Andreas mentioned early on, it will be a video showing with ultrasound. This has been done in a range of a study that we've been done together with a firm is called Ezono, where we did measurements of TA muscles and the CTA muscles using ultrasound guidance as with this probe seen here and using a navigation system. So as it's in the woman, you see the larynx very clearly in vocal cords. Side. Strong signal. This is the left side. This is the side of the paresis. So it will take me a while to find the right position. You see the thyroid cartilage. This is the navigation system. The green line shows I'm in the right level of the probe, and this scrap point points out to the tip of the needle. So I'm sort of in the muscle now. And you see this mildly reduced recruitment pattern. This is another position of the muscle and the body in there now. And this is the CT muscle. So you watch out for the thyroid cartilage and the cricoid cartilage and the CT in between. You just ask out a reduced recruitment pattern here. No synkinesis. The PCA has not been part of the study, as obviously with the ultrasound, this is very difficult to demonstrate. So this is a video about ultrasound. Into the trachea, the sound of the air, and I'm doing the drilling maneuver to get into the PCA muscle. You get some muscle activity here, and then you do the maneuvers, so you see here, the phonation, and then breathing. And you as well seen only single fiber pattern at the PCA as well. So what we have done with the lady, as we normally see patients every 3 months, it's been shown that the left vocal cord showed more signs of atrophy, and we decided we can't wait and wait for recovery, and we offered the patient a re-innovation of the left larynx with answer cervicalis, and at the same time we did an augmentation to a left vocal cord with hyaluronic acid. That was February 2018, and she was doing very well with that. So I'll show you a video after operation. The amplitudes more harmonic, nice closure of the glottis, very slightly posterior gap, but not that. Voice has been quite good.
Januar, Februar, März, April, Mai, Juni, Juli, August, September, Oktober, November, Dezember.
And as you've seen, it's been obviously a case that has not been done recently. She's been one of our first patients who's been re-innovated, but I can't show you an actual laryngoscopy. But I phoned her up just 3 days ago, and she told me she's doing fine. Her voice was absolutely good on the phone, very strong, and she's got no problems in daily life and working full days. So that was the first case I presented. So I think I give it free for questions.
Okay, are there questions from the audience? I didn't find questions in the chat. So we think everything is clear. So this case should give you an idea about the help of ultrasound for guidance. And the other one is that we have a patient-oriented therapy, a first therapy with hyaluronic acid for the first 3 months. And later on, we have the renovation effect, and this lasts. And compared to the literature, we found that the voice improved over 12-24 months compared to thyroplasty or in augmentations, where we have an improvement early, and sometimes the voice is a little bit. Yeah. So if there is no other question, we would start with the next case.
Januar, Februar.
Okay, the second case I wanted to present you is a 54-year-old female. She had done thyroid surgery in 2019 and suffered a postoperative vocal fold immobility on her right side. She had received a lot of speech therapy, about 50 hours in 1.5 years. She even had been to a voice rehabilitation in a clinical setting, which was lasting for about 5 weeks. She's a very slim, dynamic person. She's doing intensive sport, a lot of running, and she's a carpenter. She had done an augmentation to her vocal fold with hyaluronic acid in August 2020, not in our clinic. That was done in a different clinic, but the first presentation to our clinic was in December 2020. And when she presented to our clinic, she complained about dyspnea on exertion, meaning although she was doing intensive sport, she was still not content with her situation, and she was complaining about dysphonia. This has been her laryngoscopy on presentation. The right area is slightly inverted. The right vocal fold on the paramedian position. You've probably seen as well the disharmonic amplitudes and the persistent glottic gap at the posterior third. Her voice was not that bad at all.
Januar, Februar, März, April, Mai, Juni, Juli, August, September, Oktober, November, Dezember.
So we performed an EMG, On that chart on the TA on her right side, there was no spontaneous activity as you might have expected, and a slightly reduced interference pattern and some synkinetic activation at aspiration. So the TA going through the cricothyroid membrane, aiming upwards towards the side of the paresis. So insertional activity, my colleague Gerd has hit the muscle. And he will ask the patient for the maneuvers. Pronation. Calming down the patient in between is important. And then he will ask her to breathe in. And you see here this synkinetic activity. And the last maneuver will be swallowing. The second muscle is the CT on her right side. That was normal. So palpating the thyroid cartilage, aiming towards the right side and punching the contact cartilage and asking the patient for doing a glissando. Normal burst and no muscle activation. Sorry. The PCA on the right side showed no spontaneous activity on either, and a strongly reduced interference pattern. And at phonation, you will see some kinesia. So going through the CT membrane, this is a signal of the air aiming towards the side. And a woman sometimes a little bit downwards. Doing a drilling maneuver, as you see here. Going through the cartilage, and now you got muscle activity. And then Gerd will ask her to do the maneuvers. First you look for breathing, and you look for activity at breathing at the PCA muscle. There is some as well. But you will see when she phonates, there's a lot of synkinetic activity. Phonation. The synkinetic activity is stronger than the phonation activity. Swallowing. So what have we done with this patient? we did a lot of talking to her because obviously, as I've been demonstrating to you, she's been coming to us for a better voice and a better breathing, although both had been that really bad. So what we were discussing with her to do a re-augmentation, again as a temporary procedure with hyaluronic acid, to improve her voice and to see if that might improve her breathing and exertion too, because of improving her glottic closure. So what we've done in November 2020, doing a temporary procedure as well with hyaluronic acid. And we've seen her again in about 4 months' time. And her voice was not entirely changed, as you hear.
Januar, Februar, März, April.
This was her laryngoscopy after augmentation. So there was some disharmonic amplitudes, but quite good glottic closure at the moment. And basically, we discussed with her if she wanted any other treatment at the moment, but basically she arranged herself with the situation she's been in. As being a carpenter, she was having a loudspeaker now where she was compensating in her job, and she was quite content with her situation that she was in and arranged herself with it. So she didn't wish to have any other treatment for this moment being. Are there any questions?
Yeah, please feel free to interact with us. I know it's late in the afternoon, but don't hesitate to ask or raise your hands. The case want to show you that a persistent recurrent laryngeal nerve paralysis is still only to be treated to a certain amount. And I think if you look at the laryngoscopic view and all the functional results, this is a good result, and the majority, I would say 99% of all the patients would be happy with such a result, because keep in mind, today we are not able to restore mobility of the vocal folds. Every kind of therapy we use is still a compromise between improving voice or improving respiration. And she needs both, and this is a typical patient of our times. So you can tell her this 1,000 times. She again asked for better voice and better respiration. So our task in such cases is also counseling the patient about the disease and to bring her to accept the situation. And at the evening, if you think on what you can do later, you should look at new opportunities to treat such patients. So in principle, you can resolve the problem with a selective renovation, but this is a strong surgery with a lot of risks and difficulties. And until now, I think it is restricted to bilateral vocal fold paralysis. And the other way in future may be electrical stimulation. You know, we are working on the laryngeal pacemaker for the bilaterals, but together with Markus Hess, we also published first results to try electrical stimulation to adduct the immobile vocal fold. And you have seen from the EMG that she is a synkinetic renovated immobility. And this is a good condition to overcome this immobility with electrical neurostimulation in future, maybe, but only in selected cases. I think the majority of the patients will be fine with such a situation. Questions? If not, we go to the last case.
Okay, the last case, our third case has been quite, so one an elderly patient that we've just recently seen. He's 73 years old, suffered from some dysphonia since November 2019. So it's been a while after we've been seeing him. He suffered an idiopathic paresis on the left side with actual partial recovery. And the diagnostic setting has been done with no pathology in another German city, in Göttingen. He had some pre-existing vocal cord atrophy as due to his age, and he had done voice therapy in September 2020 to January 2021, with no improvement, as he told us. He first presented in September this year with dysphonia and some dysphagia on liquids. When he presented first, we've done rigid endoscopy, shown here. You see here the atrophy of the vocal folds. Some vocal fold in hypomotility on the left side, and an insufficient glottic closure. His voice was very hoarse.
Mai, Juni, Juli, August, September, Oktober, November, Dezember.
We've done an EMG on his TA. He was entirely synkinetic in all of the muscles, as you will see now. So it's my colleague Gerd doing the EMG here. Going through the cricothyroid membrane again, aiming towards the side and upwards through the TA muscle. And to ask for the maneuvers, first to phonation.
So, jetzt soll ich die Lüftung machen. I sagen. So, mal wieder ruhig.
So at phonation, almost no voluntary activity. Correction of position. So there is now.
Genau. So.
And now you should breathe.
So.
And you see this strong synkinetic activity. The CT muscle as well suffered some damage, so and it has been synkinetic re-innervated. Palpating the thyroid cartilage. Aiming towards the thyroid cartilage to the side of the muscle you want to hit. Asking the patient to do any placenta.
Jetzt sagen Sie mal bitte so viel von unten. So. Gut. Und mal so ganz hoch so.
See some activation.
Gut. Und jetzt mal so wie schnüffeln.
So you see activation at the sniffing, which shows synkinesia. The PCA Was also very symptomatic, re-innervated with small polyphasic potentials. Penetrating the thyroid cartilage, having the signal of the air, and then aiming towards the side, and penetrating cartilage to come through the PCA. And wait for the insertion activity. Listen here. Ask the patient to breathe in.
Ein bisschen unangenehm jetzt, ja? So, jetzt mal schön tief Luft bitte.
So you see some echoes there, but donation as the much stronger. What we've done with this patient, we offered him an augmentation with hyaluronic acid at both sides because of his atrophy. So this is the procedure I would like to show you there. So we use the same local anesthetic as we've done the EMG beforehand. So it's just changing the position, going through the thyroid cartilage again and aiming towards the vocal fold. So what we're watching is how many we've been injected already, and then changing to the other side. You see a little bit of blood there, but it doesn't disturb at all. We will coughing it up later on. You see the filling of the vocal fold. It's directly afterwards, we're asking for phonation there, but it will feel a bit stiff and it still needs some time to just to go over the whole vocal fold and to improve the voice. So we found it's not enough yet. That's why we just go back again. So it's been quite intense so far. That was the final result. It's got a quite good glottic closure there. So video takes a while probably. Thank you very much for your attention. Are there any questions?
Thank you, Kathleen, for this presentation and also for preparation of this presentation, because it takes a lot of time to collect all the data and to prepare the videos. Thank you for that. Do you have questions to the last case? I think we tired all people this evening. I think with this case, you could see that we can do both. We can have a clear diagnosis and prognosis estimation because you have learned today with a strong synkinetic renovation, there's no prognosis for a recovery of movement. And you have seen in this older patient that he has a presbyphonia with atrophy of both vocal folds. So, and you can help him on the same time in office without a hospital stay. If you have the experience, you have to learn to stick the needles in the right directions, to work together with 4 hands and to look with other eyes and to orientate upside down. And then you can really do surprising things for the patient. And I'm really grateful to have this team in our department to do that. But this will be not the final solution for this patient, of course, because the temporary therapy, and later on we have to think on put in fat augmentation or to do a permanent therapy for this patient. And these are our daily questions during our voice clinic, to have the right diagnostics, to have the right decisions, and to do the best therapy for our patients. And that's why we want to invite you also for the next year, maybe in presence, that you can see how we examine patients on stage and how you can learn your first steps in this field, or you can learn more if you are still experienced. That's the reason for such courses like that. And for today, we reached our result, and I want to give you the schedule for this small number of real present participants for this year in Jena. Did you see it?
Noch einen vorigen Bildschirm. Ja, jetzt. Ja.
So you can see that we met us with the participants. They are in Jena this evening at 8 o'clock. And tomorrow morning, we welcome the participants at 7:30 at the Animal Trial Center. We explained it this evening where the location is. And I hope for all the people who joined us online today that you are interested to join in future such a course. And I'm really thankful for taking your time today. And I hope you could take some messages for your further work from this course. Fabian would like to give you some informations for this evening, and from another participant of this course for an announcement.
Yes, so also hello and last words from my side. Dr. Rosa Delea has contacted me a few weeks ago and asked if she can use your audience to promote her survey. She's preparing a survey about laryngeal EMG, and of course we are happy about this effort, and we give her a few minutes to present her study, and hope that all of you will help her collecting data. But before her closing words, I also want to thank you, the people behind the stage who are here in the room controlling the chat, solving all the technical problems we are struggling every time. The secretaries who have invited you and bring you in the last weeks, who are rearranging all the restrictions of COVID-19, of the booking and unbooking and sending around hygiene plans. but also the people who have set up the website, who have made it possible for you to listen to this and to listen to our talks in the pre-courses. I think this is all great teamwork and is something what is not usual to do on this low cost and communal level. So thank you all of you that you made this possible for us. So now I hand over the words to Rosa Delaya. You can unmute you and present your work. Nice to have you here.
Hi, I'm Rosa Delia Ramirez.
And I am her son, Eloy. We will be presenting a survey for the audience to partake. It is a survey of laryngeal and electromyography, as it was already stated. And we will be now presenting a pre-recorded video in which there's a brief explanation of the survey for all the audience that is willing to participate. And we will be also passing on the link through the chat for the audience members.
Hello, my name is Rosa Ramirez. I am Otolaryngologist and I work in Hospital Clinical of Barcelona. Hence, I would like to thank Dr. Volk for the opportunity to present my survey regarding laryngeal electromyography. As there is a clear consensus regarding the diagnosis and the prognosis of laryngeal electromyography, LENG, I create this survey. I will be grateful if you participate should we have better understanding of the utility of LENG. Here we have the link. First section of the survey is the presentation. In section 2, I ask how many LENG one, I ask if the patient shows pain during the days and if they can tolerate more than half an hour a day. In block 2, the questions are related to the correct placement of the needle electrodes in the different laryngeal muscles. In block 3, I ask about the interpretation of the 4 basic points to evaluate in any ENT. Insertional activity, spontaneous activity at rest, the recruitment, and the waveform morphology of the action potential. In block 4, I ask about the diagnosis and the prognosis capacity of the LENG in vocal cord paralysis due to peripheral nerve involvement or mechanical causes. In block 5, I ask about the diagnosis capacity of the LENG of other neurological causes of the vocal cord paralysis, like basal ganglia, upper motor neuron, neuromuscular junction, and hepatic disorder. In block 6, I ask about the identification of laryngeal dystonia, tremor, and synkinesis. The last question is if you are interested in making reports quantifying amplitude, time, and frequency of the action potential, because now the reports are qualitative or semi-quantitative. Thank you for your attention.
That would be the presentation of our survey. And now I will be passing the link through the chat of the meeting.
Thank you for the presentation. Can you send the can you send the link around? But you can also use the email address if you want. It was open to all of you. Tomorrow we will start at 8:30 at the animal facilities, and we have a short meeting there before and introduction into the security areas. And So as you see here on the map, 8:30. Go here through the front doors. This is an open area, and there's an entrance here in the corner, in there and up the stairs, and here in the big meeting room. And afterwards, we can go to the changing rooms downstairs for the female, and around the corner over outside to the changing room for the male. And then later we will all meet in the operation rooms. But first of you find this gate at Dornburger Straße 23, a wooden gate in a brick wall, and then meeting up here. But you have my phone numbers, they were in the email, so feel free to phone me if you don't find it. I think that's too early, Andreas. The time schedule is so that this
8 Uhr ist Treffpunkt umgezogen.
8:30. He decided.
38.
No.
Also dann 8 Uhr Treffpunkt.
Yeah. So I will be there at 8, but we will not start before 8:30, before everyone is there. Don't worry about this small group. It shouldn't be a problem.
Okay.
Good. Thank you, and have a good night. See you tomorrow, hopefully.
So. Machst du keinen Aufnahmestopp?
Also das bügelt schon selbst aus, ja.